The Back to School Conference is designed to promote the success of both you and your student with epilepsy as you transition into new stages. And our incredible opening speaker will begin that journey with us. I am so pleased to introduce to you Dr. Robin Cook. Dr. Cook completed her MD and PhD in biophysics at the Medical Scientist Training Program at the University of Michigan in 2014. And then she stayed in Ann Arbor to pursue pediatric neurology residency and an epilepsy fellowship at Michigan Medicine, graduating from that fellowship in 2020 and subsequently joining the pediatric neurology faculty at Spectrum Health Helen DeVos Children's Hospital in Grand Rapids, Michigan. Dr. Cook is interested in complex epilepsy and also enjoys evaluating and caring for general neurology patients. She has particular interests in neurocritical care, EEG, functional neurological symptom disorder, psychogenic non-epileptic events, neurocutaneous disorders, and migraines. So with gratitude, presenting today on epilepsy care and shared decision making, I am so honored to welcome Dr. Robin Cook. Welcome.
Thank you very much for that kind introduction. I'm so excited to be here today. Let me go ahead and get my slides up here. So I'm very excited to be a part of the team presenting today because this is a topic that I actually feel very passionately about and feel that's very important to the care of our children with epilepsy. So as part of the mission statement for the session today, basically I'll be discussing shared decision-making for children with epilepsy. And so in this session, we're going to basically cast a vision for shared decision-making and talk about best practices. We'll be going through basically a set of different topics here. I'm going to start out by kind of discussing, what shared decision-making is and why we should use it in pediatric epilepsy. We'll review some structural frameworks for shared decision-making so that you kind of understand how the interaction between the provider and the patient or the patient's family needs to be set up in order for this to work. We'll go through some barriers or roadblocks to shared decision-making. Including kind of, focusing on what you as a patient or a family can do to sort of overcome those roadblocks and make shared decision-making work for you as a way to get to your epilepsy goals. And then we'll kind of move on and talk just a little bit about the future of shared decision-making in epilepsy care and what we need to be doing as a field to kind of promote that as we go forward. So what is shared decision-making? Well, shared decision-making occurs basically when a healthcare provider and a patient work together to make a healthcare decision that's best for the patient. So we're talking about an interchange here. It's part of a relationship, a partnership, if you will. And the optimal decision basically takes into account evidence-based information about the available options, the provider's knowledge and experience within the field, and the patient's values and preferences. And so you could look at this as kind of being a way that you use to get from where you're at to whatever your goal is within the patient's care. So why use this approach, in epilepsy care? Well, we actually don't have a lot of data to tell us how shared decision-making as an approach affects epilepsy outcomes. However, within about the last 10 or 15 years, along with increased focus on patient-centered care in medicine in general, there has been a big move within the field of epilepsy to try to incorporate more shared decision, particularly in pediatric epilepsy. The most recent kind of call to arms on this topic, has come basically within the last year, as over the spring and summer of 2021, the National Coordinating Center for Epilepsy, which is basically part of the American Academy of Pediatrics, conducted a needs assessment or a survey basically to better understand what patients and families within pediatric epilepsy needed. What did they need to have changed about their care? So they got input from over 300 parents and caregivers, over 100 young adult patients, and over 50 health professionals. And with the data that they acquired, they put together a strategic agenda to kind of inform, what changes need to be made in the field going forward. And one of the three kind of primary ideas that came out of this is that, we're all very well aware that shared decision-making is a cornerstone of quality healthcare, of the patient-centered care approach. But despite awareness about that, patients and families still report feeling dismissed and not taken seriously by healthcare professionals, by their doctors and their EPPs. When shared decision-making was used, it was positively correlated with patients' perceptions of having good access to care and having high quality care. And that was true for both families of children with epilepsy and for young people with epilepsy. In addition, both of those groups actually reported feeling less negative about their child's epilepsy if they had been using a shared decision-making approach with their provider. And so I think, the takeaway point from all of this is that even if we don't have enough research to tell us whether shared decision-making actually affects epilepsy outcomes, we do have plenty of data to say that it does affect satisfaction with epilepsy care, and that, that it is a very important thing for us to try to learn to do. And this approach, I do want to say, is something that can be applied outside of just the provider and patient relationship, or the provider and family relationship. I mean, this concept or these structures have a lot of potential, I think, to be applied in other aspects of the lives of people with epilepsy as well. So as we kind of transition into talking about the structure of a shared decision-making encounter, we'll kind of focus on some different approaches that can be used to kind of have these discussions. So here's a diagram that is fairly simple and kind of lays out basically how these discussions or talks go. So basically, when you're talking about making a medical decision for your child with epilepsy, the provider is going to explain what the decision is that needs to be made. So they'll talk about kind of what we're trying to decide about. They'll then assess the desired degree for decision involvement. So how much say do you want to have in the decision? Would you really rather that the provider try to make most of the decision and kind of guide you or tell you what to do? Or would you rather be the one to make that choice yourself? The provider needs to use evidence-based data to explain basically all the treatment options and the respective pros and cons of each treatment, along with the probabilities of different outcomes associated with each treatment and any uncertainty about what the outcome could look like. The next step in the process is to kind of identify patient values and preferences. So basically figure out what's important to the patient and their family. And then what we try to do is match the patient's preferences and their values to the right treatment option. And the thing to remember with this is that there's lots of decisions to be made in patient care, and this turns into kind of a cycle where we go through these steps again and again as we move forward in taking care of young people with epilepsy. So another kind of concept or structure for these encounters that's maybe a little bit easier to remember has been proposed by the Agency for Healthcare Research and Quality. And this is the SHARE approach. So this is a standardized approach to shared decision-making that has a little acronym to go with it to help providers remember how to do it, basically. So we start with the S, which is seek your patient's participation. So we're going to communicate to the family or to the patient that a choice exists and invite them to be involved in the decision. We try to help the patient and the family explore and compare options. So we're going to discuss the benefits and the harms of each option with you. We'll try to assess your values and your preferences, take into account what matters most to you, what's important to you. And then we decide together on basically the best option. We reach a decision and arrange for a time to kind of follow up on that decision, at which time we evaluate the decision and decide, whether it worked out well, whether it didn't work out well. And we check on essentially kind of how follow through with the decision went, and kind of go back to the start of the process for the next step going forward. So I think examples are typically pretty helpful in kind of understanding how these encounters run. So the more kind of typical traditional or paternalistic approach to medical decision making, we can illustrate it by taking an example, right? So let's say Sarah is a 17 or 18-year-old young person with epilepsy. And let's say that she's been seizure-free on Keppra or levetiracetam for 2 years. So a traditional kind of paternalistic, encounter in the epilepsy office would be basically me saying to Sarah, okay, so since you've been seizure-free for 2 years, it's time to start weaning your anti-seizure medicine. I put instructions for how to do that over the next 4 weeks in your paperwork. You should start weaning tonight, and as soon as you start the wean, you can't drive for 6 months, and then we need you to complete an overnight EEG after that 6 months, and just make sure you aren't having any subtle seizures before you start driving again. Do you have any questions about that? So as you can see, there are some perks to this approach in that it's simple and it takes, very little time. But the big downside here is that Sarah doesn't have a say in whether or not this works for her life. She doesn't have any choice in this approach in terms of whether this is a good time to do this or whether she even wants to take the risk of coming off medicine. Given that it's possible that she'll have breakthrough seizures if the medicine's weaned. So if we look at this same example within the framework of the share approach, it becomes basically a dialogue between the provider and the patient. So I say to Sarah, okay, since you've been seizure-free for 2 years, we can talk about whether you'd like to try weaning your anti-seizure medicine. Would you like to help me make that decision? And let's say Sarah says yes. And I say, well, okay, so if we wean, you'll need to stop driving for 6 months, and you'll need to be seizure-free on an overnight EEG before you start driving again. If we don't wean, you can continue to keep driving. The risks associated with weaning anti-seizure medicine after someone has been seizure-free for 2 years basically involve the risk of return of seizures. So, we know that if you've been seizure-free on medicine for 2 years or more, you'll have probably a 50% chance or less that you're going to have breakthrough seizures. But that chance will still be higher than if we didn't wean your medicine. And so let's say Sarah says that she does want to wean her medicine at some point, but basically right now she's got a summer job. She's working in a diner, 5 days a week in the evenings. She needs to be able to drive to the job. But she tells me she's starting college at MSU in the fall, and they don't allow freshmen to have cars on campus anyway. So I reflect that back to her. I say, well, what I'm hearing is that you actually really need to be able to drive right now, but in about 3 or 4 months, you'll be starting college. You won't have a car anyway. And I say, well, how about you stay on your medication for now, and then we can schedule a video visit to rediscuss how to wean the medicine in about 3 months. That lets you drive while you need to, but it gives you the option to wean your medication as soon as it's more convenient for you to have a driving restriction. So basically what we're doing here is trying to figure out how Sarah's values, her preferences, what her social situation is like, and how that fits in with the decision that we're going to make about her care. To move on, basically, one of the things about kind of the shared decision-making paradigm is that most of the approaches are not tailored to pediatrics or to working with children. And so I think, the AAP has put out a paper within the last 3 or 4 years here that actually, puts together kind of a algorithm or a 4-step shared approach that's sort of helpful in, I think, illustrating, some of the subtleties of all of this. It's important to kind of recognize that not all decisions or not all situations are actually well suited to shared decision-making. And that shared decision-making in real life is typically a continuum, with some patients or some situations kind of requiring more provider guidance, and some more requiring that parents take the lead in making the choice. And so this is an algorithm that we as providers can use to assist in kind of thinking about this. And I thought it might be kind of helpful, for you as families, patients, folks that, are in the school system and working with patients with epilepsy to kind of understand this paradigm as well. So it's a complex, kind of algorithm here, but bear with me as we kind of break this down. So the first step here is we're looking at basically whether the decision includes more than one medically reasonable option. So medical decisions in which there's really only one reasonable treatment choice actually require a different decision-making approach than shared decision-making. And that's because shared decision-making requires that there actually be a real choice, meaning several different treatment options exist with different possible outcomes. And those options have what we would call clinical equipoise. So basically all the options are medically reasonable or are consistent with the standard of care. So what's the standard of care? Well, basically, this is kind of an unwritten set of rules that guides professional practice and requires physicians and other providers to provide basically the same care that all other or most other physicians would provide under the same circumstances. And it's in keeping with the principle of first do no harm. So basically, providers are wanting to do what is scientifically most likely to help the patient and least likely to hurt them. And the consequences of kind of not following the standard of care include, just being negligent in your practice, as well as things like malpractice suits or losing your license or professional discipline. And the standard of care is defined by evidence-based medicine. So this includes interventions whose safety and effectiveness is based on good quality scientific evidence, or professional guidelines and consensus. So if there's really only one treatment option that fits within the standard of care, then we're going to use a simple consent model. We're going to explain the option and we're going to say, do you agree with me that this is what we should do, knowing that there's not really a lot of other choices. It's either this or do nothing. So an example of this to kind of simplify it is that, basically if you're asking me how to get from Ann Arbor to Kalamazoo, there's really only one reasonable way to do that. And that's take 94 West. Any other way that you go is not going to be as quick. It's not going to make as much sense as this option, basically. But if you're trying to go from Ann Arbor to Traverse City, right, it's going to be about 3 hours and 50 minutes, whether you go north on 23 to get to 75, or you go over to Lansing and get on 127 and go north to get to Traverse City. So this would be an example of where you can use shared decision making. We can have, kind of a conversation about this and figure out which option is better for you. Moving on, so if we go to step 2 in kind of the algorithm here, what we're asking at this point is, of the options that are out there, is there one that's medically favorable, right? So is there one that has fewer risks and more potential to help the patient than the other options? And if that's the case, then ideally you want to have the physician kind of making the stronger kind of voice, or being the stronger kind of voice in this, and kind of helping direct the decision making a little bit more. If all the options are relatively similar, then we're going to kind of veer more towards the parent side of the spectrum. And this is kind of a continuum, and every decision that we make can fall at a different place, sort of in this spectrum. So an example here in terms of the travel analogy, right, is like, I live in Grand Rapids. If you want to go to Traverse City, probably the fastest way, which has pretty nice scenery and still, is the fewest miles, is to go north on 131. Now you can also go around over by the coast, which has really nice scenery, but it takes an hour longer and it's 40 more miles. So, I mean, this, is probably the favorable, option of the two. And this is probably what I would encourage most people to do. Moving on, our next question is basically, how preference sensitive are the options? And so the goal of this step is to ensure that the patient's and the parents' values and preferences align with the chosen option. And the provider's role here, my role as the doctor, is to kind of help figure out what those values and preferences are, and then help provide you with information or guidance to kind of shape those preferences or to inform them. So that we can get to a choice that's, the best choice medically speaking, and also the best choice to fit in with your life. And so this is a relational and discussion-based process. We're just trying to figure out what's important to you, and, basically how can we apply this to the specific situation and help rank the choices that we have. And part of this, as I've kind of touched on already, is just, do you as the patient and the family, do you want a more active role, or do you prefer to have more guidance? And so that can kind of guide where you end up on this spectrum as well. So for example, if we're taking the Ann Arbor to Traverse City route again, and I have a family who tells me, well, we really prefer country driving, we get kind of stressed out by the interstate. Then I say, okay, well then, I take 96 up to 127 and drive that way, and that'll be a better route for you. Whereas if I say, or if I talk to a family who says, well, we'd really rather take the interstate, then I say 75 north is the way to go. So I want to pause here a little bit and just acknowledge that I think this is a place where many providers actually struggle. I think many families, don't come into visits expecting to need to discuss what's important to them, with their provider. And so this requires actually some time and some thoughtful dialogue, which can really be a challenge, in a day when a provider has kind of back-to-back appointments scheduled all day and you're trying not to be late for the next, next family. I think, social history is a place where, we tend to often get sidelined, kind of during busy days or in busy practices. And it's a place where some of the questions we ask, I think sometimes feel kind of intrusive to families almost, but, as we discuss this process, it is really important that a provider know kind of what a family's life looks like in order to be able to help the family choose options. And so this involves things like, are there two different homes that the child is going between? And what's the communication like between the parents? Are there siblings or parents with health difficulties of their own? If the patient is a young person with epilepsy, a teenager with epilepsy, we may want the parent to step out for a little while just so that we can talk to the patient one-on-one about whether there's anything that could affect their care that they don't feel comfortable talking about in front of the parents. I think, one thing that's important to know as a patient is that it is okay to ask for assistance in figuring out how your values apply to the situation. So it may actually help to tell the provider, we feel that X is true of our child, or that X is very important to us, and then specifically ask what option aligns best with that idea or with that principle, right? You can say to the provider, if this is important to you, or if this was important to you, then what would you do? Or if this was the most important thing to you, then what would you do? And I think that helps us kind of better understand where you're coming from, and helps us help you make the choice that's the best for your child and your family. So the last step in this process basically here is, again, kind of just a focus on recognizing that this whole, process is a continuum, right? So it's not a one-to-one 50-50 parent-patient and 50% like physician approach. In places where there's a clearly preferable option, like a medication that's more likely to be effective for that particular kind of epilepsy and is going to be better tolerated than most of the other options, and the parents don't really have strong values or preferences that affect the choice, the physician is going to be the one that's kind of strongly recommending what to do. Whereas, I think if all options are fairly medically equivalent, and the family has a strong preference for one based on side effect profile or how complex the dosing regimen is, then the parent should be the one that kind of makes that choice, or most of that choice. So I'm going to shift gears here a little bit and move on to talking about some of the barriers or roadblocks that we encounter in shared decision making. In other words, kind of what are we trying to avoid? So, we say we're going from Grand Rapids to Traverse City again, you can actually get to Traverse City from Grand Rapids by way of Chicago and Milwaukee in the Upper Peninsula. Now it's going to take you 15 hours, and for most people, that's probably not the best option. So this is one of the things that we're trying to avoid, is taking a lot longer, much more difficult route to get to our goal than we have to. And then the other thing that we're trying to avoid, right, is ending up in a different place than we were actually trying to go. So, say you get on the highway and you're trying to get to Traverse City, but you actually end up in Toledo. So I'll look at this from a couple of different sides here. And as we discuss this, I think some big points are just that most providers don't have any formal training in how to do shared decision making. And most patients also don't have any training in this approach, or really, an understanding of kind of any formal structure to these dialogues. I think that said, there may be some families and some providers out there who are listening to this talk going, well, duh, and saying that, this is all very intuitive kind of stuff about how this encounter should be structured. But there's also, a lot of other kind of providers and families that just don't find this very intuitive at all. And so I think it's worth consciously thinking about some of the things that both we as providers and you as patients and families run into, as we go on this journey. So what are some of the barriers from a patient side? So I think some of the main ones that we run into are just families or patients being unaware that there's a decision to make, or, even more of the time, not being emotionally prepared to make the decision. Many families are more comfortable with kind of a traditional paternalistic approach to decision making. And then I think one of the other barriers that is out there is just kind of having a limited understanding of sort of how medicine and patient care works and what that paradigm looks like. Making it hard for you to kind of be on the same level as the provider in terms of, what their approach is going to be like. So with regards to the roadblock of being unaware that there's a decision to make, or not being emotionally prepared to make a decision. So that's something that happens, I think, quite often, actually, when we have families with a new diagnosis of epilepsy, or who are taking a big step in their patient's epilepsy care. Like, for example, the first time you talk about having the possibility of having epilepsy surgery. So oftentimes, I think families and patients just are too kind of emotionally shell-shocked by the beginning part of the discussion to really be able to participate in shared decision-making much during the first visit where you talk about this. And it is totally fine. I think, as a family and as a patient, it's totally fine to let the provider know that you're not ready for that part of the discussion yet, that you need time to process things. And one thing that's been really great about the pandemic, actually, and the kind of 10 years of progress within 3 months that we made in telemedicine, is that in a lot of practices now, it's pretty easy actually to schedule a telemedicine follow-up visit within the next couple of weeks, where you can rediscuss the treatment options and kind of decide on which thing that you want to do. You can always ask for written information about some of the options, and see if you can get back to the provider within a few days, with more questions or with whatever choice you'd like to make. And that's not always possible or safe from a medical standpoint, but you can certainly ask. So there are ways to kind of get around this. I think, another thing that we encounter in terms of the patient's approach is that there are a lot of families that are just much more comfortable with kind of the traditional paternalistic approach to medical decision making. So this is a family that comes into my office and says, after I've kind of presented the idea that we need to make a choice about something, they just say, "You're the doctor, you decide. We don't know anything about this." And I think a lot of this typically kind of comes from situations where there's a cultural deference to or respect for medical providers, which it's an honor, but it's also kind of terrifying as a provider, I think, to be given that kind of responsibility. And, I think it comes up very often in families where their education has been in fields other than science or medicine, or where there's a cognitive or learning disability on the part of the patient or the parents. I think the general public is just not all that comfortable with medical terminology and statistics, and that makes, participating in these decisions really scary and challenging on some level for a lot of folks. So what typically happens, or what we try to do in this situation, is we try to do what you want us to do and take a more active role and attempt to kind of walk in your shoes. And so what this is it's still shared decision making, but it's kind of on the provider guided end of the spectrum. And one note that I'll make here is that many younger providers are actually somewhat uncomfortable with this approach, as it feels like kind of a reversion to the old days when the doctor just dictated the plan to everybody. And I would be prepared that if you ask for this in some situations, the providers may actually want to think about the choice for a little bit of time, or talk with one of their colleagues and get back to you. Very commonly, this happens, as we're approaching workup for epilepsy surgery. Actually, we almost all centers will actually present a patient's case at a multidisciplinary conference to get a consensus amongst the doctors and other providers before they come back to you with a proposal about what they think the best option will be. I think another roadblock here is just patients and families kind of having a limited understanding of sort of where we're coming from as providers in terms of needing to adhere to the standard of care and all of that. So I think, one thing that we very commonly hear from families is, that we only want natural treatments for our child. I don't want my child on medication at all. And I think we really struggle when we hear this. I think, these kinds of things, phrasing things in this way can kind of set up a lot of barriers in the mind of the providers. So when we hear the term natural treatments, most of us are trained, to know that even natural treatments are drugs. They're modifying the way that the body works, and they do come with risk of side effects. And for some situations within our field, medication therapy is the standard of care. And so if we offer you anything else besides medicines, it's not within that standard of care. It's not a medically reasonable choice. So one thing I would advise, if you feel like these kind of statements are ringing bells, is that you just try to reframe the narrative, basically. So what you want to do is try to tell the provider what's important to you, rather than leading with a restriction of the options or with a negative, right? So you want to say something like, we would like to choose the least risky option in terms of potential side effects, even if that means it might not work as well to stop the seizures. You might say something like, well, we as a family, we really try to minimize prescription medication use. Are there any non-medicine choices that we could talk about to treat the epilepsy at this point in time? And so that opens a window for the provider to basically be able to say, well, these are the non-medical or non-medicine choices, non-pharmacological options that we use to treat epilepsy. And here's kind of why those aren't part of sort of what I would recommend that we think about doing right now. And it brings us back into this domain of the dialogue, as opposed to setting up, barriers between the provider and the patient or family. So I'll talk quickly through some of the sort of barriers that I think we run into that are more on the provider side now as well. And the emphasis here is going to be on things that you can do as a patient or as a family to try to help get around these. So I think for providers, time is a big consideration when it comes to shared decision making, and concerns about how much time it takes to complete the steps of this. The lack of training is a big issue here. And then just pessimism, I think, or skepticism that patients will be able to productively participate in medical decision making is also a big barrier. So, I've alluded to this previously, but discussing multiple options with the family and kind of assessing their values and preferences and then making a plan together, that all takes time. And it's really important to do it, but it's something that we can't always predict when we schedule a visit, which particular visits are going to require that we take this approach. And I think we as providers really need to recognize that in the long run, time input and shared decision-making up front is going to save time, and it's going to save a lot of pain in terms of outcomes. But I think, things that we both as providers and patients can do is be conscious to try to schedule a longer visit, right? So we can ask for a 1 hour extended follow-up visit when it's clear that we need to have a discussion in terms of shared decision making. So for example, when I'm going to discuss the possibility of epilepsy surgery, for the first time with a family, I try to make that an extended visit so that there's plenty of time to go through all the kind of ins and outs of the choices that we're going to be making in terms of the testing. we can try to discuss expected decisions in advance of when they actually need to be made at an office visit, right? So we say, well, if you're going to have, if you have a breakthrough seizure before we see you in the office the next time, we should probably talk about just what medication we're going to add if that happens. And so here are some of the options, and we can use shared decision making to make a choice about that before it actually becomes an issue. With regards to kind of everything I've covered today so far, most residency programs are kind of incorporating shared decision-making informally as they train new practitioners. But there are a lot of providers that trained prior to, about 2000, 2005 that just may not have encountered this concept or really may not feel that it's the best approach. They may prefer to kind of take the more traditional paternalistic approach to encounters. And I think it's really important that we as a field start to incorporate some formal teaching on this and to try to provide continuing medication on continuing medical education on shared decision making. I think, what you as a patient and a family can do about this is just that if shared decision making is important to you and your provider doesn't seem open to that, even when you kind of ask directly about it, it's okay to seek out another opinion, knowing that you might have to wait or switch centers in order to get to that provider that's a good fit for you. And then I think the final barrier that I wanted to discuss from a provider perspective is just that, providers frequently kind of encounter behavioral barriers or situations which can jeopardize their ability to make sure they're providing. Sorry? To make sure they're providing the best possible care for their patients. And I think sometimes that unfortunately results in some distrust about families' ability to actually participate in the process. But so the thing about this is a place where the patient and the family are really, really empowered to make a positive change in kind of how the provider approaches things, right? So if you come to visits and you know your child's current medications and doses, you know their history in terms of what medicines they've been on in the past, you know how many breakthrough seizures they've had since they were seen in clinic the last time, and you're compliant with the plan that has been in place since the last visit, this is going to buy you a lot of credence and a lot of trust from your provider, and it's going to really help with sort of facilitating this dialogue that you need to have. If between visits you feel like the plan needs to be changed, you want to reach out to the provider instead of kind of, trying to make the plan on your own. Just because you're both partners in this process, right? You're working together, and so everybody needs to know what everybody else is doing. When you do research, which is a great thing, we love when families come to visits, educated about, their child's particular epilepsy syndrome. You want to try to use reliable resources. So things like the Epilepsy Foundation website, the International League Against Epilepsy website, the NORD and NIH and NINDS websites are all great places to look for information about different epilepsy syndromes. So we're kind of approaching the end of our time together here, and I will just very quickly hit on basically what the future of shared decision-making I think looks like within pediatric epilepsy. So clearly we've kind of talked about how we need to set up some sort of structured formal training for providers on shared decision-making, both during training and as continuing medical education. And part of that is going to be that we need to, figure out how we can kind of briefly set up expectations for families at diagnosis about how we do this, right? Like how these discussions go. I think one big part of this field where we have a lot of opportunity, where there's a lot of work still to be done, is the development of epilepsy-specific decision aids. So a decision aid is basically a simple document, a one-page sheet usually, that kind of lists out some of the options that we're facing at a particular point, in somebody's epilepsy care, and lists some of the data or outcomes or possibilities associated with each of those options. So you can just actually have them laid out and compare them to each other. And I'll show an example of that. And then I'll touch on shortly here that just, I think we do need actually to do a lot more research regarding how shared decision-making influences epilepsy outcomes. So this is an example of an option grid. This would be one for adult epilepsy, and it's on epilepsy treatments when you're considering becoming pregnant. And so basically, I won't go through this whole thing, but essentially we're comparing, 3 different medicines as options in the situation where somebody's on valproic acid already, but is thinking about trying to become pregnant. And so, along the left side here, basically we have a list of kind of all the relevant questions that come up as somebody's thinking about switching their therapy in preparation to trying to get pregnant. And so this is an example of basically a document that you could take home from the visit and look at, show to your family, use to kind of help guide your thinking when making the choice that's best for you. I think a big thing to think about here as well is just that, we've kind of demonstrated, right, that shared decision-making really improves patient satisfaction. It improves how they think about their relationship with their provider and how they think about their epilepsy. But we do need further research in terms of understanding how shared decision-making actually influences epilepsy outcomes. So as I was preparing for this talk, I was searching on PubMed, the medical database that we use to, to find papers when we're trying to figure out what the evidence is in certain situations. And at most, there were 11 papers published in 2019. And prior to that, prior to 2012, basically, there were not really hardly any papers published on this topic. And this is, kind of within the context of like, there are some topics, within medical care where there's tens of thousands of papers published every year. So I think what we need here basically is information on, questions like, does shared decision-making for youth with epilepsy improve medication compliance? Does it improve the number of kids that are taking their medicines regularly? Does it improve anxiety and depression rates? And this is important because part of what happens here, I think, is that, as I mentioned, time is a really big barrier for providers in taking this approach. Time is money to a lot of the big healthcare systems that many of us work for and work with. And so the only way that we can get the insurances to kind of cover the time that it takes to do shared decision-making is if we're able to demonstrate that this approach really results in better outcomes and reduced costs in the long run. So we've kind of covered a lot today, but in summary, shared decision-making is a central part of patient-centered care and of providing high-quality care for people with epilepsy. And we as providers really need to take the responsibility to understand shared decision-making approaches and use them. And I think my biggest takeaway from this talk is just that you as the patient and the patient's family, you do have the power to help overcome roadblocks to shared decision-making in your care. And so if this is something that's really important to you, I think there's a lot of things that you can do to kind of promote that. So with that said, I'd like to thank the Epilepsy Foundation for the opportunity to speak today, and the faculty at the University of Michigan for many, many years of excellent mentorship received during residency and epilepsy fellowship. And then just all my colleagues at Spectrum Health, Helen DeVos Children's Hospital within pediatric neurology and pediatric epilepsy. And I would be happy to take any questions that anybody has.
Great. What a tremendous talk. Thank you. This is so relevant for people's experiences and what they need in their healthcare. And so we thank you, Dr. Cook, for that. To everyone, we do have a time of Q&A here for about 10 minutes. So if you have a question for Dr. Cook, you can put that in the Q&A feature at the bottom of your Zoom screen, and we will get to as many of those as we can. So I'd like to begin, Dr. Cook. If a family feels that their doctor has been pretty paternalistic and maybe they're wanting a more shared approach, what might be a good way to initiate that conversation in a way that would make communication effective?
Yeah, so I think, I think one thing that happens a lot, right, is that within the time constraints of a kind of a traditional office visit, there are a lot of providers that are kind of trying to make sure they get everything done in timely fashion. And so they just, I think many people just may not be thinking about whether you want a voice in this process or not. And I think that's particularly true for providers that trained, earlier, kind of prior to all of this becoming something that we were all a little bit more aware of. So, but I think, most providers actually, if you just flat out say, well, one of the things I was really hoping to talk about today is just that we'd really like to have a little bit more of a voice kind of in the process. We have, some ideas about kind of what we'd like to try this time around at this visit. Can I tell you about that? So you just kind of ask permission to sort of, tell the provider a little bit about your values and preferences. And I think if you come into the visit sort of knowing exactly what you want to say before you get there, that can be really helpful, because again, if you can deliver that concisely to the provider, then they can instantly take that and say, well, how does that apply to the options? And then, toss the ball back to you in terms of kind of what fits best with what your preferences are. So being prepared, in other words, for the visit in terms of knowing what your own values and preferences are, and just concisely giving those to the doctor can be helpful, I think.
Yeah, and just feeling empowered to do it. I think you've helped us think through that a bit more today too. So thank you for that.
Yeah.
You mentioned that one of the things that could be helpful both on the provider side and the patient side are longer visits, and we know that is not always possible for every visit. But one question we have is, would it be appropriate to request a longer appointment time to discuss, harder topics or more difficult or more complex topics? Or could a patient and a family possibly send along thoughts ahead of time? What might be helpful there?
So I think those are both great ideas, actually, for how to approach this. So we can't. It's difficult because within the pressures of the hospital system, right? There is sort of a pressure most places to see a certain number of patients and all of that, which is just an unfortunate thing about the way our healthcare system works. But that said, if you specifically ask, because you feel you're going to need a longer visit, or if you send along thoughts, for example, through the patient portal about what you'd like to prioritize talking about at your visit, that can actually really be super helpful for providers, because then we get in the room and we say, oh, great, these are the things we need to focus on today. And we can make sure we get your concerns taken care of up front, right? So I think those are both really great ideas on how to kind of facilitate the process.
Love that. Thank you.
Yeah.
How do you handle shared decision making when there are language barriers or cultural barriers?
So that is a great example of a time when I very often will request a longer visit, right? So we still really try to use that approach, but I think it does become more complicated. And the main thing is it just takes more time when everything that either party says goes through an interpreter, right? And so, I think one of the ways that I specifically try to handle that is just by kind of getting a feel again for that social history, right? So where is the family from? What does the family dynamic look like at home in terms of who plays which roles? Who's working outside the home? Who's taking care of the children? From a religious perspective, kind of where is the family at? And I think all of that can kind of help give the provider a little bit of insight into sort of whether they're going to want the provider to kind of be more guiding decisions. But often I just also straight up ask, I say, do you want me to make these choices for you? Do you want me to think about where you're at and try to tell you the right thing to do? And most of the time families and patients will tell me if that's what they want. So that's kind of how that gets handled, I think, a lot of the time.
Yeah, thank you for that. If a family either doesn't like a doctor's approach and they're looking for a different physician, or if they're just looking for a physician for the first time, are there ways that they can get a sense of what a physician's approach might be?
Mm-hmm.
Mm-hmm.
So I think, a lot of patients that I meet, for the first time, it's a little bit harder when you're coming in and it's potentially a new diagnosis of epilepsy, right? But if you know your child has epilepsy, many times through the Epilepsy Foundation, through talking with other families online, through just people you know in the community, you can get a sense of kind of what different providers' approaches are like at different centers. And so that's, word of mouth is really going to be your best way to kind of figure that out. It's also fine to try to ask when you get an appointment somewhere for the first time, if you can, tell them what you want basically in a provider, and just say it briefly, like a sentence or two, but say it's really important to us that we have a provider that uses shared decision making. You can say that. And sometimes what'll happen is they'll shoot the referral over actually to one of the doctors within the group, who can then kind of say, oh, well, this might be better for, this specific doctor or this specific nurse practitioner, as opposed to others in the group.
Yeah, thank you. One question is, what options are out there right now other than surgery or new meds, or are there new meds? How have things changed? This person asks, I've been trying to keep up with things so that I can best know what would be good for me to try next. And I know that's obviously a question for that person and their doctor, but what are there new things on the horizon that you find yourself potentially talking about with families?
I think so. So it's hard to go outside the bounds of medication or surgery, right? Because a lot of our options fall in one of those two camps. I mean, if you're talking completely non-surgical and completely non-medication based, basically what you're kind of discussing then is the ketogenic diet or the modified Atkins diet at this point. I think what I would say is within the epilepsy surgery field, I mean, that field is a lot broader than it used to be, right? So instead of just kind of resective, surgeries where we go in and take out the piece of the brain that the seizures are coming from, we now have responsive neurostimulation, which is, a treatment where we go in and actually place electrodes within the brain around the place that we feel the seizures are coming from, that both provide your doctor with a readout of what the activity looks like electrically, and also can provide electrical stimulation to try to target the seizures and try to reduce the seizure activity. And so I think neuromodulation in particular is going to be just a huge thing, within our field going forward. It already is something that we're, just super, super excited about, because it's offering potential for so many more patients to, kind of get on that treatment that may help them minimize the number of medications they have to take and the number of side effects that they have. So many more patients are kind of candidates for that now than they would have, than we would have had be candidates for surgery when there was just resective surgery as an option. So that's a really exciting thing.
It is so exciting. And I would say to anyone here as well, we do have an innovation conference every year where we talk about what's new, what sort of questions are emerging in epilepsy care. And you can find all our recordings from our previous conferences on our YouTube channel, and we can put that in the chat for you. And please know that this conversation is being recorded today as well, so you can go back and watch this presentation once more. It has been absolutely so valuable. So Dr. Cook, I want to thank you for your time, your expertise, and also the ways you've empowered families to feel like they have some expertise in this. Of course they do, knowing their own rhythms, their own values, their own hopes. So thank you for this time. And I would invite anybody in the chat to share gratitude for Dr. Cook. And thank you so much for being with us today.
Thank you so much for the opportunity to be here. I really appreciate it.
Yeah, you're welcome. Thank you. We have so many other exciting sessions lined up for you today. And in fact, we are about to move to our second one. It is so relevant for so many families who are dealing with a child who has epilepsy. And this session is entitled Crafting Student IEP 504 and Seizure Action Plans. And I'm looking forward to introducing our panelists today. I want to begin by thanking them for being present for this important and timely topic in the life of our community. So I'd like to welcome Dara Wilson, parent mentor at Michigan Alliance for Families. Becky Bigelow, parent of a child with epilepsy and a special education teacher at Pellston Public Schools, and Kelly Kiss, a special education 504 coordinator in Saginaw Township Schools, and one of our new board members at the Epilepsy Foundation of Michigan. We believe this is a vital conversation for all of us here. I know so many of you likely have questions that are happening right now in the lives of your families. So we welcome you to this time of learning, and we will discuss innovative strategies and tools that will help you move into this school year with a clear plan in place to ensure your students' safety and their success. So welcome here, everyone, to this session. And I would like to begin by inviting panelists to introduce themselves. I'm curious, why is this topic important to you and your work? And I'm wondering if we could start with Dara today. Welcome.
Hello, everyone. I am a regional parent mentor for Michigan Alliance for Families. I cover Central Wayne County. There are 3 mentors for Wayne County because we're so densely populated and all the different school districts. So Central Wayne County covers Detroit, Highland Park, Hamtramck, Grosse Pointe, and Harper Woods. And I work closely with the advocate who comes from Park Detroit. Thinking about the importance of it, I think back when I was a child, and a lot of the stigmatisms that comes with children in school when they have seizures. And I remember a lot, now as I think about it, I remember what the poor child might have gone through because of the stigmatism of them having seizures in school. People just not knowing what to do. As I became a mom and an adult, I don't have any seizure disorders myself, but I've had family members that have. But just overall in my advocacy, I just believe in awareness. And when you bring awareness to things, people have a better understanding. So as my role, I'm here to bring more awareness to anybody I come across. I don't care where I am. Kind of not righting wrongs, but giving more information so that we can know better ways to deal with people and have better understanding. So that's important to me, to make sure that people have an understanding, but also those that go through, everybody has something that they go through in life. And when we encounter something, we look for more information about it so that we can be better at it. We can maybe prevent things and we can be prepared. So though all of those things encompass why it's so important, to do what all of us do, to bring that awareness so that people can be more empathetic, more helpful, more resourceful, more knowledgeable, and more helpful again.
Yes, yes, I love that.
And actually, I was a CPR instructor also. So I did teach some, seizure procedures, as well as I worked at Head Start for 15 years. So that was a definitely mandated training we had every year.
Good.
And just like I said, just to know what to do. It's scary when anybody has any kind of situation. Nobody is anticipating things, but when you know what to do, you can handle the situation better and you can be more helpful.
Yeah, empowered. I love that. Thank you. And Becky, would you please introduce yourself and what makes these topics so significant to you?
Yeah, hi everyone. My name is Becky Bigelow, and I have a 14-year-old son with DeVos syndrome. And if you haven't heard of that syndrome, basically it's just a rare genetic form of epilepsy. And I also am a special education teacher. So I have taught in a K-5 resource room for 12 years now. And so I have that unique perspective of being a parent with a kiddo with epilepsy, and then also, the teacher in the school aspect of things. So that's.
Thank you. And thank you for wearing both of those hats today. It's so valuable. Thank you. And Kelly, welcome to you. I'm so glad that you're here. How about you?
Good morning, everyone. My journey with epilepsy started as I've been a special education teacher for 25 years, taught in 3 to 5 year olds with different disabilities. And so was introduced to epilepsy at that point, had multiple kids that had epilepsy. And so I was trained very early on what to do when there's a seizure, making sure all my staff was trained. And then my cousin Jenna Rose was diagnosed with epilepsy and passed away a few years ago. So my heart has been in, making sure everybody with epilepsy in schools knows what to do, that kind of thing. And my daughter's boyfriend also has epilepsy, and he's 20. So epilepsy is definitely a part of my life, almost my everyday life. And then on top of it, now my new job in my district is I'm a special education coordinator, and I also oversee all our 504 plans. So I get to use my passion for epilepsy and getting the word out there by making sure every child in my district is safe, has a seizure plan, parents know what to expect from us, and making parents feel comfortable to send their kids to school, that they're going to be safe, that we know what to do. And then I recently joined the Epilepsy Foundation board. So yes, epilepsy is close to my heart, and I'm glad to be here today and help all the parents out and with any questions they have about getting ready for school. It's coming quick.
We are delighted. And so, thank you, all three of you. And for anyone here, it's pretty clear that our panelists today just have a wealth of information and also people to whom they are connected. So I really want to begin with this. Can you share the basics of what IEPs are, 504 plans, what they are, seizure action plans, as well as some of the differences that they might provide? And I ask this question because there may be some people here who have a child with a new diagnosis, or we've also heard sometimes, parents have children with epilepsy and no one's really ever approached them about these to let them know that they're possible. So what are they? And if parents or caregivers have never considered these before, what might be some initial questions or actions they might ponder? Becky, could we begin with you on this one?
Yeah, I'll do my best. And we have Kelly, who's super informative, so she could hop in and help me out. But so basically, an IEP is an individualized education program plan, depending on where you're at and what that P stands for. And a 504 is similar to that. An IEP is more for receiving special education services. You can have a 504 without receiving special education services, but it would provide your accommodations, kind of protect some of those things that kiddo might need in a school setting, and then also not in a school setting. So we'll get into that later because that's one of the questions later. But so basically, it just provides services for your child. Any services that may be needed in a educationally or medically. I know 504s are more kind of associated with a medical condition. Anybody with a medical condition could have a 504 and not have an IEP, but you could have an IEP and a 504 if you're transitioning to adulthood. So yeah.
Yeah, thank you for that. And Kelly, anything you'd like to add there?
I think it's important that before you start school, every child with epilepsy should have a seizure plan. I have a student who, well, I'll talk about that in a minute, but so a seizure plan is the minimal you want to have. So that gives exactly every person that deals with that child knows what to do if they have a seizure. Gym class, music class, lunch, if they go to any other classroom. So the seizure plan needs to be in place. I wouldn't have thought my daughter's boyfriend needed it, but he had a seizure, he was seizure free for 8 years. And when he went to college, nobody knew what to, he had a seizure in his classroom and nobody knew what to do. So a seizure plan is the minimum you want to have. So you should call your school district and talk to your principal. Every school district has a designated 504 coordinator. Get with them and say, so you get a seizure plan. But my district, we like to have all of our seizure plans part of a 504 plan. So a 504 plan for some of our kiddos that have seizures at night that might not get up right away in the morning or have to take medication at a certain time, a 504 can do accommodations so your child isn't in trouble for coming to school late. So a 504 plan, any child with a disability can get, especially in our district, any child with a medical issue, we want it in a 504 plan. And then as parents, it gives you a lot of rights and your child will not be discriminated against. No one's going to say, oh, he can't go on this field trip. What if he has a seizure? Nope, that's discrimination and we're not doing it. It is ridiculous. So that 504 plan gives you those rights in writing. So I highly recommend a 504 plan. You can have one just with epilepsy, even if you don't have a lot of accommodations. If you're like, well, my kid doesn't need many accommodations. You might not now, but things can change. So I would talk to your district, but start with a seizure plan. That's the minimum you want to have starting school. And then discuss with your school district a 504 plan. And if your child needs some accommodations in school due to if they're having multiple seizures, they're going to be out a lot, they have lots of doctor's appointments, all that can be put in. You're not going to get in trouble for being gone from school for those. Now, if your child has seizures to the extent that it's affecting them in the classroom so much that their education is being impacted, that's when you ask for a special education evaluation, because that's 504 is for regular ed students, special education is for special education students and IEP. So if your child is really struggling in school due to the epilepsy, you go to your principal and teachers and you put in writing that you're requesting a special ed evaluation. So minimally start with a seizure plan. Next would be a 504 plan with accommodations. If your child's having problems and struggling in school, then you want an IEP evaluation. Hopefully that was clear.
That was great. Thank you so much. And Dara, I'm wondering if there's anything you'd like to add. And then also, if this is new for parents or families, like how might they initiate some of these processes? Like, how does someone get started?
The only thing I want to mention about the differences in the plans, well, you have the seizure action plan. You can have that developed in schools. I don't know what you'll do if you were out in the community, but if you had a job, you would also want that in place. 504 plan, you get into the laws with 504s and IEPs. The 504 plan falls under Section 504 of the Americans with Disabilities Act. That's where the laws come in place. Everything else they said was great, but just letting them know where it came from. And it falls under the Office of Civil Rights. So it's a basic rights. So the thing that's the same between the IEP and the 504 is that they both ensure free, appropriate public education in the schools, and they protect you from discrimination, as she said. 504 plans, like you said, you talk to the coordinator and have those things done. If you have additional situations that impact the education, maybe one or more impairment, then you would go for the IEP. And the IEP goes under the Individuals with Disabilities Education Act. So the IEP is an educational document. And, a lot of people, they'll have the medical diagnosis, but there's a difference between the medical diagnosis and the educational diagnosis. Of course, you need all that information together to develop a good plan. You want to have all your information. So with parents, yes, please request anything to the schools in writing. Even if you're just, during progress report time, if you're seeing some changes or you already know what your student is struggling with at home, share that information with your special ed staff, because the IEP, you have laws that go with it. It's a fluid document. It stands up in a court of law, but it can be adjusted. It's not written in stone. And that's because things change. You can change medication, have different side effects, things like that. Just always remember that the communication is important. You got to communicate everything with your doctors and your educational staff, because they have your student. Talk with your student about it. Find out what they think their triggers might be. Sometimes they can, determine when they feel a seizure is coming on. Talking with the teachers if you notice physical things that may indicate that a seizure is coming on, share those so that they can include that in the plan. But just also having teachable moments around peers, not necessarily pointing out students, but providing that information within the curriculum. I know there's health classes and things like that when when schools know that they have students with even severe diabetes. That's when that 504 plan comes into place, to include accommodations for diabetes and asthma, And those would, for an IEP, it would go under the category of other health impairment. So, you know, you have all these 13 categories, and that's where those things can be put in place where you can develop the accommodations. But the best way to do that is to have all the information. So parents, you request things in writing when you're having discussions, write things down, make notes all the time so you can get it out of your head. So you don't have to remember when you have meetings coming up, when you're planning for meetings, have you a notebook designated for your concerns, date them, get, you know, kind of journal if you notice something different, share all of this information, but get it out of your head because it can be stressful. Know who the staff is in the school to go to. Always share information with your principal, because even those special ed staff do really well with taking care of their students. Sometimes there's things that may need to be put in place that the principal needs to sign off on. The principal should know what's going on in their building. They should know what kind of students they have, what kind of health emergencies that could come up. So putting things in writing, organizing, keeping everything in one area, a folder, a binder, something, so that when things are coming up, you're just ready. You have that information. Michigan Alliance for Families, that's what we're here for, is to provide that individual mentoring for the parents and the family support, so that you know what to do next. Or if you just got a question, or you just need to wonder if you're doing the right thing, that's what the regional parent mentors are for. And we're regional because we cover our areas and we specialize in our districts, in our cities, to know what resources are available, to know what things the school districts do. You know, you go school district to school district, or in between intermediate school districts, and things change. So the mentors we're very close. We work very close to the school districts and knowing this information, so that we can provide it to families so they'll know what to expect. We have pre-recorded videos, 1-hour videos on topics. Our website is an awesome tool. We have, you can type something in, you can type in epilepsy, you can type in a 504 and learn about these things. And believe it or not, a lot of our information is connected to the Epilepsy Foundation. So you'll click on some of our links and we'll go right to your page. All of our information is vetted from Michigan Department of Education, Office of Special Education Programs. So it's accurate, it's up to date. But when you have questions, you can call us. There's no dumb questions. If there's some information that we don't have, we can direct you to someone else that can. But we understand there's so many questions, things change, and we're here to provide that information. And if, you know, it becomes a situation where you're trying to get accommodations and you can't seem to get that done, then we can refer you to an advocate that can attend meetings and help move things along. And then, you know, through dispute resolution, there's always special education mediation services. There's a process for everything. Don't give up. You know, nothing is easy in this life, but there's so many more resources out there now, and so many organizations that are here to help families. So please reach out to us. You know, that's the best way we can. And we deal with things individually. So contact somebody, look for resources, look for support groups, talk to your school staff.
Yes, thank you so much. I appreciate that. And we're so grateful for Michigan Alliance for Families. They're a great partner with us. And please know, if you have specific questions of things that are needed in your child's education, we at the Epilepsy Foundation of Michigan are here for that. We partner with other organizations, and we ourselves will sometimes attend IEP meetings if you need an advocate also. So there's a wealth of help and knowledge with us, and also with our organizations we partner with whom we are very grateful. So I have another question here too. And Kelly, I'm wondering if you can speak to this one. What are some common ways that epilepsy can impact school performance? And which of these can be improved through medical care? And which ones are more likely to require accommodations?
I mean, in my experience, students that are having multiple seizures, that it's not under control yet and are trying to attend school, obviously that's going to impact them the most. So you're going to need a lot of accommodations, and then how it's affecting their learning. So if they're struggling in school a lot, that's when a 504 isn't going to be enough. You're going to need to go to an IEP. So it all depends on where you are in your epilepsy journey and how many seizures you're having, what type of epilepsy you have. We do ask for, with like 504 plans, a letter from the doctor, just giving a diagnosis. And then doctors are really great, the ones I've been working with, about giving some accommodations they think might be helpful for that type of epilepsy. There's so many different types. And so we really like to get information from the doctors, so we know exactly what accommodations they think. Now, we don't have to, as an education, take all doctors' accommodations, but typically I do take most of them because they're a doctor, but I'm the education expert in terms of a lot of things. So we also know we don't want to over accommodate kids. We don't want to give kids too many accommodations and then we're taking away from their education. It's a fine line. And what we do is we take data. You can talk to your teachers about what data are they taking to make sure these accommodations are in place. So it just depends on what kind of a seizures you're having. Like my daughter's boyfriend had a 504 plan in high school, but he never had to use it. I don't even know how much he knew about it, which I kind of lectured his mom about, like teasing her. But it is important for kids to be able to advocate for themselves and know when and when they don't need it. But he didn't really need any in high school because he had been seizure free for a while, but now he goes to college and he needs a 504 plan. So everyone is different, what type of seizures you're having, how it's affecting their brain and their learning. And you, just like Dara said, you are your child's advocate, and be that advocate. And you're talking to your teachers and you're talking to the staff there. And most teachers I know, I feel like, would say to you, he's having problems learning and there's an issue. And then that's when you need to go into that special education evaluation. Did that answer all those, Renee? I know there was a double question.
Oh, that's great. Yeah, thank you. I appreciate that very much. And I'm also curious, and Dara, if you want to speak to this, feel free, but like, what role does assessment play with these plans, and what typically happens with an assessment? What should parents expect?
Well, assessments are key. You can't build an IEP plan, or you can't successfully look at what type of accommodations or modifications need to be in place without assessments. When you're going through an evaluation for an IEP, they have to look at least two different areas. So for epilepsy, if they're having, memory issues, they want to have, or speech, concerns as a result, you might have a speech and language pathologist do an evaluation. You may have the psychologist, they look at the educational part, what kind of learners they are, the IQ, those types of things. They may even want a social worker involved if they're having depression, if it's affecting other things. And a lot of that is going to depend on the parents, because to give that information on that social emotional status of the student, and it's very key, because sometimes that's the first thing you really have to look at, is getting their mental status together so that you can progress, so that they can know that, so they can be hopeful, and so that they can know that we're going to do these things. We're going to put these things in place for you, and we're going to help you, and you're going to be successful. You may have some difficult times, but we're going to put that in the plan so that everyone knows that. And it's okay that they know that. Not everybody has to know your business, but there are key people that, just talking to the student, letting them know that these are people that will be, doing testing discreetly and things like that. But you have to look at the data. You take in consideration what the medical information is, but educational evaluations are just that, looking at how the educational progress and academics are affected by the disability. And then on an individual basis, because you can't say that everything is going to affect everyone the same way. So knowing these things, you have to do observations to get to the information to find this out. And by law, for an IEP, IDEA says there should be a 30 school day timeline. That's not So it's difficult when people get in the fall of the school year and you wait, say, well, it's November 1st. You got all those holidays. So, you probably won't get an IEP till late January or, just you got to consider those things. But when you know them ahead of time, you can, but don't wait when you have concerns, because even just talking to your teachers, they may be able to, put some minor accommodations or, something in place. But assessments, you have to collect the data in order to put these things in place. And then, you worry about, is the data saying, who the student really is, but that's when the teacher's observations and other things come into place also.
Thank you.
Renee, if I could add to that really
Please.
quick. Dara sparked a thought of mine, and that was, when you start the process, there's a meeting called a read. And during that read, it's really important as a parent that you bring up all of those concerned areas, because then those are areas that, like Dara said, we can collect data in and we can do assessments in. And there's a lot of different assessments that can be done for a whole lot of different areas of need, like your social needs, your adaptive needs, your speech and language, your occupational therapy needs, all of that, all of those concerns can, make sure that as a parent, you're providing some really good input into that first meeting of all of your concerns, so that all of those specific areas hopefully can be addressed during that evaluation process.
Yes,
Yeah,
thank you, Becky. And that READ stands for, let me see, it's a review of existing educational data. So parents, your comments are very important, because those concerns go into that document. So that, some parents say, well, I talked about this in the IEP. The first thing I go and try to see if they actually put those concerns in there. And you can always go back and have them do that. But yes, it's a lot of terminology attached with it. There's different stages of the IEP process. That read is very important. That's when you're trying to think of everything, as Becky said, to be addressed. That's before the evaluation start.
Yeah, and I so appreciate you naming those things too, Becky, because one of the things I know I've heard Becky talk about, as she's just been like a friend and mentor in this process to other people, is like, get specific, get it in writing, get specific, because that's when also, if there ever are issues, you have a way to come to the table. And also, if there's ever a dispute, it's right here. It's said in the IEP plan, or it's said in the 504. And I so appreciate that. Becky, a follow-up question for you too. In your experience, are there any shortcomings to traditional school-based assessments when it comes to epilepsy, or are there ever any other type of assessments that needed to be added on in some way? And if there are alternatives or other things we need to add on, do schools ever pay for those?
Yeah, so I'll talk from a parent perspective on this one, because so I've had the opportunity to have my son Eli evaluated at school, and then also evaluated in the medical field. And a lot of times, though, that data is pretty accurate. I mean, they pretty much match each other. And so sometimes we get disheartened as parents because something might not turn out the way that we think that it should turn out, or the way that we see that it should turn out. But, when you have two different entities kind of, validating that information, then it's very reflective as a parent to say, okay, so maybe I'm looking at, maybe I'm not quite looking at this the way that I need to for school. And so it's very reflective that way. From my perspective, all of the evaluations that I've had done seem to be very well-rounded. So they've looked at a lot of different areas, and not just academic status or cognitive or some of that cognitive testing. They've looked at the adaptation and his speech and language and all of those things. But that to me ties back to the read a little bit, because if you don't let them know that, if nobody's seeing some of these, some of your concerns at home, then they don't know what to test for it. And so, the only thing that I can say is that if you ever, I'm not really sure about alternatives, maybe somebody else could speak to that, but I do know And I'm also in our parent group that meets weekly through the Epilepsy Foundation, but I have heard some stories in there that parents have been unhappy with the evaluation that the school has given them. And I do know at that point that you have rights as parents. And so you can request an independent evaluation to be done. And it would be at the school's cost if they granted that request. But they could also, file a due process hearing for that. So like that would kind of be an option if the evaluation that the school came out with was, not what you expected as a parent, or not what you were happy with, and you wanted to see something else. But like I said, in the medical field, your neurologist can put you in line to do some of that testing too. And so sometimes that's really helpful as a parent to know that like this educational evaluation totally matched up with what the neurologist had ordered too. So yeah.
Very, very helpful. Thank you. Kelly, a question for you. When we think about accommodations and services obviously should be individualized to help each student's needs, but are there some that are most common or most helpful, more frequent, that are used for students with epilepsy?
When I think about the 504s I have in place right now for students with epilepsy, like I said, a lot of it is that attendance, coming to school late, excuse for doctor's appointments. In terms of like accommodations for homework and that kind of thing, I think we just put one in for one student who does seem to miss more school. So they are giving 1 to 2 extra days to turn assignments and homework in. So that's a very common one. And like if any child, like testing in a different place, being in a smaller area when they're taking a test, so they're not as stressed about it. For some kids, we don't want kids stressed because that's a trigger. So testing in a smaller classroom, testing somewhere else, sometimes that helps a lot of our kiddos out too. But those are the main ones I'm seeing, but every child is different, like we just said. And so you have to be the advocate for what your student needs. And when they start to struggle and you show them all their grades and that data, that's when your school really needs to relook at the 504 plan. And I think Dara said it earlier. 504 plans and IEPs are written and they're legal. They're very fluid. An amendment, we can make changes. Kids sometimes meet goals or do things well, and they don't need those accommodations. The parents are like, he's seizure free for 2 years. I don't want him to have 1 or 2 extra days anymore. And we meet as a team with the teacher and the parent. We decide if that accommodation is needed anymore. So they're fluid. If you start out with a lot and then you need to take some back, that's easily doable. So don't ever feel like once you put an accommodation on there, it has to be on there forever.
Yeah, thank you for that. And another question too, Dara, you mentioned just these IEP meetings and revisiting and things like that. Can the students sometimes attend an IEP meeting and put their voice into the process too?
Most definitely. Part of what our mentorship is for self-advocacy also. So when students are in high school, they and they have an IEP, they go through, they have a transition IEP. And that includes the student and just looking at, their future. What do you see for yourself? What do you want to put in place? What do you want to do? What are your goals? Just getting them involved in planning and looking at that. And that's by law is required to be done by their 16th birthday. But the recommendation is to start that process at maybe like 14. My son, he has attention deficit and he's 13. So maybe like last year or the year before that, I started talking to him about his IEP, and he's always known about his attention deficit and he's always talked about those things. So I started giving him the labels that goes with it and preparing him. So he's in 8th grade this year. He was held back a year. Those things happen with attention deficit, but we're moving forward. So just just planning for self advocacy, letting them know that, you know, adults are here. You know, that's just the whole way of teaching him, period, is if you need help talking to the adults. But if you're having problems, even like with bullying, talk to the adults. So it can be in writing, but knowing just who you can go to talk to, your counselors or, you know, whoever that they may have, an ally, social worker. But just knowing and letting the students know that this is you, this is your life. Disabilities don't usually go away. You can put things in place to make them better. And so that making them more mindful of, well, you know, I struggle. My son would tell me, you know, I forgot, or I would tell him something and I'm like, okay, I had to make sure I didn't give him too many steps. But if I did, he would come back. And then, you know, he was like, you know, I just forget. And then I would start teaching him ways to help him remember or to focus, or ask him, well, how do you think you can get from here to here and actually remember what you were supposed to do? Just talking to them about being aware of themselves and realizing that they can put plans in place with goals, lives, careers, the same thing. You know, you struggle with this, you have to go through life. What do you think you can put in place that would help you get through that? So it's important for them to have input because they know what helps. At that point, they can talk to you about it. They've gone through their lives at least 14, 15 years and have an idea. But, you know, adults can assist and let them know what some of those other things can be. So that self-advocacy is important, you know, as we're all raising young adults and children. I just wanted to go back with it. Some of those accommodations for the 504 plan. Well, if you go to our website under, I'm not sure if it was under the epilepsy tab or under 504s, but there's a link to Pacer Center. They have a lot of informative documents for students with disabilities, and they have a whole section on this school accommodations for students with section 504. So, and it just talks about, you know, how with your books or, you know, handwriting issues, don't forget assistive technology, those types of accommodations too. But yeah, self-advocacy is very important, but it's important that the student knows some of the things that can help them so that they can verbalize it and communicate it as well.
Yeah, thank you for all of that. And that's really important information. And I would also say to everyone here, we are here to help you feel empowered as parents and as caregivers. And we're also here to help your children feel that sense of advocacy. So two things I'd love to mention, one that's already come up a number of times, and then one that I want to call your attention to. We do have a parents group that meets on Tuesday nights from 8 to 9 p.m. Becky just mentioned that. She is often there. And this is such a great place of both support and resourcing. Sometimes we have had parents show up and say like, oh, I didn't even know I could ask that question, or that maybe I might ask that question or ponder this process or move in this direction. Sometimes we need to hear from folks who have already done that, you know, and especially if this journey is new for you in some way. So we will put that link again in the chat here in a moment. You can join us over Zoom for that. Another thing I want to make sure that you know about is if you have a teenager with epilepsy, we have an upcoming program called eSMART. It's a great acronym. It stands for Epilepsy, Self-Management, Advocacy, there's that word, and Resilience for Teens. This is going to be on Thursday nights coming up soon, starting August 18th. And we will put in some more information there. It's going to be from 5 to 6 p.m. We have more spaces. We would really love for you to sign up very quickly. So glad to have you with that. Becky, I have a question for you as well. Obviously, these plans, IEPs, 504 seizure action plans can be used and should be used as appropriately in the classroom. Are there other settings where these plans might be used? In sports, in extracurricular?
Yeah.
With friends?
Sure. So I kind of touched on it, and I'll talk about it to my knowledge, because you know, maybe we don't know everything. We learn new stuff every day. But to my knowledge, an IEP and 504, like Kelly had already touched on, a 504 can be used anywhere out, like at a job, college. Your 504 is going to follow you to college. So those type of things, your IEP and those accommodations can be, from my understanding, those accommodations and modifications and such, the things that are protected in the IEP will also allow you to participate in, not allow you to, but those accommodations are going to follow you. Those accommodations and supports would follow you into school provided activities. So, like a football, swim team, if it's a school related event, then those IEP accommodations will follow you automatically. Most outside entities like, a community soccer or things like that are very accommodating too. But they wouldn't, your IEP wouldn't, those accommodations wouldn't necessarily be held accountable for those accommodations like they would for public school events.
Yeah, very good. Thank you so much for that. It's nice to know that these can be helpful in all those settings too. Kelly, when a family is engaging a school, if they feel like they're not being heard, or if they feel like there's some kind of conflict moving around hopes for accommodations and assistance with IEPs, et cetera, like what's a good approach to try to resolve some of those needs?
So when you're in this process and you don't, because we do have parents that have moved into our district and said the last district we were in really gave us a lot of pushback about a 504 plan, and I don't understand it, but I know what happens. So when you start with your 504 plan and you're working with a team, if you're getting pushback, you start in your school district and then you go to like the principal, and if they're not already involved, and then you're going to go to your superintendent going, help me understand. My child has epilepsy and I'm getting pushback on some accommodations that I think are, because we don't, for me as a school district, I want to work as a team with my families, because I don't want Office of Civil Rights called in on a complaint. And that's kind of the process. So then you get to your superintendent level, your 504 coordinator. So like our middle school counselors handle our 504 plans, but then if parents are upset, then they reach out to me. And so far, fingers crossed, it continues, we've been able to work through our issues at that point. But if not, sometimes they will go to the superintendent and we try to work from there. But parents, I would say, and Dara can help. There's advocates out there in your area that will go to these meetings with you. When my nephew was diagnosed with Asperger's and he's in Indiana, guess who was his advocate? This girl. You have advocates, you have people that will help you through that process. And as a parent, they're going to hand you your rights. If they don't hand you your rights, they're already in trouble. Every single meeting, I give my parents the rights and you can look through it. But through special education, you can file a complaint there. And then with the 504, it's Office of Civil Rights, and they take these things very seriously. So when I'm working with my team and they're giving me pushback, I'm always like, we need to try this accommodation and see if it works and get data before we just say, nope, we're not doing it. So be an advocate, parents, in those meetings. And then if you need to bring someone in with you, call Dara, go to Michigan Alliance, find out who the advocates are in your area and get one of them to go with you. But start with your teacher and your principal, move up to your 504 coordinator. If you're not happy, go to your superintendent. And if you're still not being heard, that's when you need to get an advocate and take the next steps.
So good.
I just wanted to add to that really quick. In my own personal life, even with all the education that I have, I needed to reach out to Michigan Alliance for Families, because I was sure in my heart that, there was something that I wanted for my son that I wasn't getting, that the school district was really giving me pushback on. And so I just wanted to let you know that like,
I think we lost her. She's frozen. Oh, there you are, Becky. You were frozen.
Okay.
And I was just saying that the Michigan Alliance for Families is an amazing resource. I even reached out to Renee, like a late night email, and I was like, I need help.
Yeah, thank you. We're so grateful for that connection. And if any of you all are needing that advocacy, like that's something that we provide. That's something that Michigan Alliance for Families provides. And we're really grateful for all forms of advocacy. So absolutely feel free to reach out and we will get you connected. I would actually like to go ahead and move on to Q&A because we have so many wonderful questions from folks who are here.
Renee, can I just say before piggybacking on everything, there's a new series out through the Disability Network of Southwest Michigan that we're collaborating with them on. As you were talking about involving the students in self-advocacy, there's it's the series is called Paving the Way to Self-Determination. And actually the ages are from 0 to 12 because they usually provide a lot of this information, you know, charting the life course and everything for the older students. But this would be a series for the younger population. They have topics on the supportive decision making and Social Security and things like that too. So they can look for those resources. Also, another one was how to ask for accommodation. So that was just something else to add to that the advocacy part.
I love it. And that makes me feel like we're covering the whole gamut because you said from 0 to 12.
0 to 12.
But, and our program, so that's the program, you know, if you have younger children, please reach out. We'll get you connected to that. And then eSmart is for teens 13 to 17. So we've got it all covered right there. I love it. So a question, some people who have IEPs, some students with IEPs will go on to get a diploma. Others will go on to get a certificate of completion. And could one of you tell us what that process is?
I mean, and Dara, you might know a little bit more about it because most of my experience with special ed in terms of that kind of stuff was more in the younger areas. But being a coordinator now, I've had a little experience with it. That is a team decision. An IEP team decision. We had to do it with my nephew, which I know it was really hard for my brother and sister-in-law, but you have to make that determination at a certain point, like what is your ultimate goal for the child? So a certificate of completion is going to be if your child has, you know, a lot of services and needs. For most of our students with epilepsy that I have seen, they are going to get a diploma because they're just going to need those accommodations. But in that rare occasion that it's really affecting their education and they're not able to do all those and complete the course requirements or credit requirements for high school, they'll get that diploma, a different diploma instead. But that will never be done. And if it ever is, then you have a nice complaint on your hands because it has to be part of the IEP process. You all are part of, as a parent, you are all a part of that process. You're the biggest part. You're the most important part. And if that decision is ever made without you, you need to get an advocate immediately.
Thank you so much. One thing that was mentioned earlier is about every district having a 504 coordinator. Someone asked, is it a state mandate that every district must have a 504 coordinator?
Yes, they have to have, every school district has to have someone with my title, 504 coordinator. So every district would have one. Before me, pre-COVID, it was our curriculum director because the principals and everybody handled it. When COVID hit and all that fun started in our educational world, and I was doing one job, they're like, will you be our coordinator for 504s also? So it's off of our principals for a while. So, and then our curriculum director did it. Now I'm doing it and I'm overseeing all of them. So your website for your school district should have who their 504 coordinator is. If not, you need to ask your principals and or your superintendent who the 504 coordinator is for your district and know who they are because you're going to start with your teachers and your principals or your counselors. And if you're not getting anywhere, you're going right to your 504 coordinator with any concerns that you have.
Great. Okay.
And I wanted to say that the diploma versus the certificate of completion, it's not the end of the world if your student isn't getting a diploma. You know, it's there as an alternative, an option, because you want to keep them to continually being educated. So that's why in Michigan, special education goes up to 26. So when they are on track with meeting that credit requirement for the Michigan merit curriculum, that alternative is that certificate of completion. And it just means that, you know, they don't get a diploma, but once they are And you have to look at the schools with the age limit where the students actually physically 10, and then whatever the district programs are, their transition programs. But if they get that certificate, that covers them till age 26, which means they are still covered under those laws that, protects them, provides them with that free appropriate education so they can continue to learn life skills. And they're in Detroit, we have transition programs, transition schools. One of them, they have a farm, Drew Farm. They're teaching agriculture. What other life skills for the severe students? It just extends that educational opportunity so that they can continue to work on those skills, and actually they can continue to work on their diploma. A lot of people don't know that you can still go towards that diploma if you have that IEP in place. But like Kelly said, putting those things in the plan and saying that that's something to work towards. And those things kind of come up early, like in high school, 9th grade, when you're doing that planning and that transition plan, to make sure that those things are covered. Or sometimes parents find out in 11th grade that your student isn't on track credit wise and they're so far behind, and that's really sad if they wait that long to find that out and they're devastated. But they need to know that there are options and it's not devastating. It could actually be very beneficial depending on your individual student.
That is so helpful, and you are so right. And I want to thank you all so much for being here today. This has been so important. Thank you for the information and also your passion as you speak it. We do have some more questions in the chat, but we will get to all of those if we were not able to voice them aloud. But please join me in thanking our wonderful panel here. And please know also this information was all recorded today and it will be shared with you for reference. So thank you, please help me in giving gratitude to Dara and Becky and Kelly. Thank you so much. Next, we welcome Brianna Romines, president of the Epilepsy Foundation of Michigan. She is going to share more about the fervent work taking place to make Michigan a seizure-safe school state. So please welcome Brianna. Thank you.
Thank you, Renee, and good afternoon, everyone. My name is Brianna Romines, and I'm honored to serve as president for the Epilepsy Foundation of Michigan. I hope that you all have enjoyed our back to school conference and all that it has offered so far, and there is still more to come. As evident by this conference, our foundation is committed to doing everything we can to support a safe and enriching learning environment for students with epilepsy. And one of the ways we are doing this is by pursuing the Seizure Safe Schools Act right here in Michigan. Now, before we get into the status of the bill locally, I thought I would take this chance to update you on the nationwide movement that is sweeping across the country towards the collective goal to raise awareness and implement a uniform standard of care. And of course, this is so students with epilepsy have full access to the care they need so they reach their full academic potential. To date, 18 states have passed the Seizure Safe Schools Act. In April 2018, Kentucky became the first state to pass this law, affectionately named the Lindsey Crunk Act. Through efforts by the Epilepsy Foundation of Kentuckiana and Lindsey Crunk, who is a 17-year-old Epilepsy Foundation Teen Speak Up ambassador, they made up their minds that this bill was needed. And with that, the first bill of its kind passed in less than 2 years. This act of advocacy has spurred a call for state legislation to follow suit and pass bills that ensure all school personnel, such as teachers, paraprofessionals, and bus drivers, are not only prepared, but can recognize and respond appropriately and efficiently to students experiencing seizures. So let's talk about Michigan's Seizure Safe Schools Act, House Bill 4970. It's important to know that the bill has 4 main components. Number 1, training school personnel on seizure detection and first aid response. Number 2, requiring a seizure action plan, which we just heard so much about in their importance, be on file for every student diagnosed with epilepsy or a seizure disorder, and require those plans to be available to all personnel responsible for that student. Number 3, ensuring the administration of medications approved by the U.S. Food and Drug Administration, and most notably our rescue medications. And 4, a Good Samaritan clause. House Bill 4970 was introduced by our friend and ally, House Representative Jack O'Malley. Now, Rep. O'Malley has a son with epilepsy and immediately saw the need for this bill. After introducing the bill, it was assigned to the House Education Committee and given a public hearing. Together with our advocates, we testified before the House Education Committee, and the bill received a majority vote and was passed out of committee and sent to the House floor for a vote. The Seizure Safe Schools Act was passed with overwhelming support out of the House and was promptly sent to the Senate. House Bill 4970 was then assigned to the Senate Education and Career Readiness Committee, and that is where our bill currently sits. Senator Lana Tice is the current chairwoman of that committee. I've personally met with Chairwoman Tice and almost every member of that committee to date. I'm happy to report that we have garnered majority support in this committee, but have not yet been granted a hearing by Senator Tice. So if this is an effort that you support, this is an area where you can help. Please reach out to Senator Tice and ask that House Bill 4970 get granted a hearing as soon as the legislature resumes in September. She currently holds the control in this bill advancing. And because of the way the Michigan legislature is designed, if the bill does not get signed by the governor by the end of this calendar year, we have to start over from the beginning in January. So please join us in helping to make this bill a reality for all students living with epilepsy. To learn more about this effort and all of the public policy efforts that we champion, please visit our website to learn more. We also recommend that you reach to your own personal state legislature members to express your support for 4970. And to make this as easy as possible, we have a link that we will put in the chat soon that will help you in sharing your story while expressing your support for House Bill 4970. Thank you all for all that you're already doing to further our collective mission. And if there are any questions in the chat, I'm happy to take them at this time. Renee?
Thank you so much. It is really an honor for us to be doing this work, and we want to thank all of you who are a part of it, who have reached out to your legislators and others, and thank you for all of that. Yeah, why is it taking so long? Someone asks. Sure.
Well, that's a great question. And let me also just say, we are right alongside you in the sense of urgency, I think, that we all feel to make this bill come a reality. The short answer is that passing bills takes a fair amount of time. To kind of name the process from start to finish, once a bill gets introduced, it gets assigned to a committee. It has to pass out a committee to go to one chamber. Then it has to go through the process in the entire next chamber. So again, a committee, a floor vote, and then in front of the governor. So it is just a lot of steps. And again, as mentioned, the legislature here is on a 2-year cycle. And so any bills that do not complete that process in that 2-year time frame have to start all back over. And so that is why you'll see certain pieces of legislation just certainly feel like they take forever.
Yeah, we absolutely feel that urgency with you, and the need is so vital. We know this, and with or without a bill, please know we are always working to help school educators, other school personnel be trained in seizure first aid. And you can also request that from your school. And that is a training that we can provide. There is also on-demand training through the Epilepsy Foundation of America. So these things are available, and we're always going to be working for it. And we also do want this mandate. Brianna, just very briefly, could you tell us about the role of the PTA and how they have been helping with this too?
Yes, thank you so much for bringing up our friends and partners at the Michigan PTA. So probably no surprise to this group. We've got plenty of parents out there that have had their eye on this legislation as it's been passing across the country. And so after we introduced it here in Michigan, so fortunate to get a proactive reach out from the Michigan PTA and with the simple question of, how can we help? How can we make this happen? And so we have just been working hand in hand with our Michigan PTA folks. And one of the most notable things that have happened has at their national conference recently, I believe it took place in July. they had a resolution formally supporting the Seizure Safe Schools Act, and it had unanimous vote. That means every PTA in every school district across the entire state of Michigan passed that resolution. And so we're just so grateful to have their support. So it's if perhaps on social media you follow us and you follow Michigan PTA, you'll see that we're lock in step with regards to action alerts and other things trying to make the Seizure Safe Schools Act pass this year.
Yeah, thank you. And thank you for your tireless work, Brianna. You have done so much on this. Thank you for being such a champion with it.
My honor,
To our
my honor.
community, also championing this legislation. Successful healthcare transition and beyond. As our students with epilepsy grow into adolescence and emerging adulthood, it's important to prioritize transition so they can become empowered to take an increasingly active role in managing their healthcare and vocational goals. So in this session, we will explore frameworks to raise vital questions and take action steps with transition planning. We're very excited for that. So we have another incredible panel joining us today. Please welcome our dear friend, Russ, Derry, Pediatric Epilepsy Coordinator at Michigan Medicine, and he is no stranger to any of you, a great friend to many on this call. He served for 21 years as the Director of Education right here at the Epilepsy Foundation of Michigan. And we are also joined by two incredible individuals from our community, Olivia Moses, a young adult with epilepsy, and also Ria Sandhu, a teen with epilepsy. So welcome to all three of you. Welcome. Great to see you here. Good. Well, as we begin, I'm wondering if we could have a little introduction from each one of you, and if you could share briefly your experience with this topic, maybe why it's important to you. So Russ, I'm wondering if we can begin with you.
Sure. Again, my name's Russ Derry.
Russ, we're not hearing you.
You're not?
It doesn't look like you're muted.
No, we can hear him.
That's just me. Sorry.
Okay. Panic there a little bit.
Sorry.
No, I'm the new Pediatric Epilepsy Program Coordinator at CS Mott Children's Hospital. I started that role in January, and so both at my years at the foundation and in my new role, transition planning is an element. So back when I worked with the Michigan Pediatric Epilepsy Program or project at the foundation, that was a key focus area of the project. So dealt a lot with that. That's something that's worked into the eSmart program that you've been mentioning. So that's a key element of that program, which I worked with you, Renee, to develop that program. And then in my current role at Mott Children's Hospital, that's something I'm going to be increasingly discussing with parents and teens as when they're at the hospital. Potentially getting long-term EEG monitoring or other inpatient stays or after outpatient visits, just spending some time talking with them about where they're at with their transition planning and what are some of the next steps they can take. So it's kind of where I'm at with transition planning. So
love that. Thank you. And Ria, how about you? Could you introduce yourself?
Hello, I'm Ria. I'm gonna be a 12th grader now, and I am at the Westwoodville High School, and I've been there for 4 years now. I started my seizures when I was 5 years old, and now I got another kind of seizure, but I'm okay now. It's still working. I'm still I can make my own goals and do them. I'm still doing okay with my other ones also. It's sometimes a little hard, but I just have to make my own goals and go through them.
And you're doing it, which I love. In fact, Ria was part of our eSmart program too. So
yeah, and I was in eSmart. I enjoyed the class a lot, and I want to join again. It's very fun for me. And I love to learn about epilepsy all the time and learn to do my own goals when I can, and when I can do it myself, even at home, just to make my own goals.
Sure. I love it. And today we're going to learn from you, which is great. So thank you. We're all learning from you. Olivia, could you introduce yourself?
Yeah. Hi, I'm Olivia Moses. And I obviously have epilepsy. I'm 20.
I can't tell if Olivia's screen is frozen. Oh, I think so. Or is it mine? Can you all hear me?
No,
3
her
years
screen is
old.
frozen.
Okay. Olivia, we'll come back to you absolutely as well. So I think we'll come right back to hearing from you, which I definitely want to do. Yeah, thank you. It's been really a joy to know Olivia too. She's involved in our young adult group and is just a great leader. So I'm wondering, with transition planning, what is it? What are we talking about when we use a phrase like that? And how can transition planning be practiced in the home, in the school, in the healthcare setting? Russ, I'm wondering if you can speak to that.
Sure. Transition planning really kind of involves identifying your current level of knowledge and skills related to kind of managing your adult life. So everyone has a certain set of skills and knowledge that they can apply to adult life. And so kind of assessing that where you're at currently, and then taking gradual steps to try and build those skills and build that knowledge so that by the time you reach 18 or by the time you reach 21 or 26 or whatever you personally define adulthood as, you're mostly ready to handle the day-to-day aspects of adult life. And that involves not only, general skills, but also skills related to specifically managing epilepsy. So in the home setting, again, in a general sense, it can involve transition planning can involve taking on additional responsibilities around the house, like doing your own laundry, learning more about financial literacy, like how do credit cards work, how do you balance a checkbook, learning how to cook meals, basically taking on some general adult skills when you're still a teenager or a child. And then related to epilepsy, that can involve taking on some more responsibilities for managing your own condition. And we'll talk more about what those responsibilities include. In the school, it's working with school staff to start to plan more about what type of coursework do you need to reach your goals in adulthood. It's starting to think about college. It's starting to think about employment. If maybe college is not the route you're going to take, what about employment? Or starting to think about building independent living skills in the school setting. It can also include, advocating for yourself and maybe teaching other kids about your epilepsy. And then in the healthcare setting, transition planning can involve, doing kind of an assessment of your current skills related to and knowledge related to epilepsy and healthcare, and again, beginning to take a more active role in your medical appointments, so that you're the one talking with the doctor rather than your parent. Learning more about how your medications and how they work, and learning more about health insurance and how to navigate health insurance. So all of those types of things are involved and start prior to the actual transfer of care, where you go from pediatric neurology to adult neurology. So and generally overall, the earlier you start with that, the better. So even though we're talking about developing adult skills, it's not a bad idea for people to start doing this around age 12 or 13 or so. So fairly early on, you can start, again, gradually adding on more and more responsibilities for managing your own epilepsy and managing your own life.
Yeah, Thank you. Yeah, that's great. That was a great introduction and definition of what we are talking about here. It's wonderful. And speaking of the medical pieces of this, what are some of the differences between the pediatric care model and the adult care model? And how is healthcare transition more detailed than just simply switching doctors? That's just one part of it. Can you tell us a little bit about that?
Sure. So, I mean, these are definitely generalizations, but in general, there tends to be a little less hand-holding in the adult healthcare setting. You're kind of expected to do more for yourself. You're not necessarily going to be guided through the process of healthcare as much as you would in the pediatric environment. Patients may have a little less time with their providers than you might have in a pediatric appointment. There's maybe less emphasis on care coordination, so working as a team together. So if you have, multiple providers, you may have to take on a more active role in actually making sure that those providers are talking to each other. Additionally, adult neurologists are maybe a little bit less familiar with childhood epilepsy syndromes or epilepsy syndromes that begin in childhood, like childhood absence epilepsy or juvenile myoclonic epilepsy or Lennox-Gastaut syndrome or any types of epilepsy syndromes that begin in childhood. They also may be less familiar with other developmental disabilities like autism or other things that begin that are more commonly associated with childhood, like ADHD, even though these things often do persist into adulthood. They just may be a little less familiarity with managing those conditions. So those are just some of the differences that kind of jump out at me between the pediatric and adult care models. So in addition to, you asked about switching, what else is there beyond just simply switching doctors? Young adults really have to choose from the various levels of involvement with their family members that they can have. So how much are parents going to be involved or other family members going to be involved in their healthcare decisions? How much are they going to be in, how much access are they going to have to that personal health information? Those are decisions that you start to need to make prior to that transition. Who's going to come to appointments? Will you have a legally appointed guardian? Will you have a health advocate, or will there be power of attorney? So there's some legal questions that in some cases you may need to consider. You want to think about who's going to have access to my healthcare portal and the information in there. Is it just going to be me, or am I going to allow other people to access that? So those are some of the things that you would have to consider. Yeah, and then also many people with epilepsy, as they're transitioning to adulthood, in addition to finding a new neurologist, they'll also have to find a new primary care physician. And then others with more complex epilepsies may need to not only find a new PCP and neurologist, but also maybe a new physical therapist or occupational therapist or cardiologist or whatever other members of your healthcare team you may have. And one other thing I would mention is too, if that transfer of care is likely to take place while you're in college, you have to decide whether you want to find a provider that's closer to your parents' home or whether you want to find one that's closer to wherever your college is. That's another kind of decision you want to start to think about prior to that actual transfer of care.
Great answers. Thank you for that. And Olivia, I'd like to come back to you. We wanted to get your introduction in, and if you heard anything from Russ there that you'd like to speak to, I also would welcome that.
Yeah. Oh gosh, I'm seeing that my internet connection is unstable again.
I can hear you though.
Okay.
Okay. So yeah, it's okay.
Cool. So I'm Olivia. My internet connection is unstable. My My medical connection, though, is pretty good. I'm with Michigan Medicine, and I had my first seizure when I was 9, and we didn't know what it was. Nobody in the United States knew what it was. It went to all these major hospitals. Think of any major hospital in the States. They didn't know what it was. And they actually diagnosed me right on the spot at Toronto Sick Kids across the border in Canada with central nervous system vasculitis. And we're like, what's that? And so, yeah, I went through a lot of different procedures, and I now have a deep brain stimulator. So, yeah, that's me in a nutshell. I was also thinking there are a lot of different paths that people take, and I happened to be able to go to college and graduate, and right now I have a job. But it depends on the person. I also have a very protective dad, so he is sort of always wondering, how are you doing? Oh, but you're so much better than you were. And sometimes as a protective parent that has been, seeing things happen to their child, and it's heartbreaking, and you don't know what's happening and what to do, you really want to make sure that your kid is getting better, and they're going to be better, and it's always going to get better. But sometimes the child is more so like, right, but I'm still not feeling great. And also I need to become an adult, and I'm taking care of myself, and I know what's best for me. And I think that is something that as a parent, you need to grasp as well. So adding on to what Russ was talking about, you need to help your child as much as they want you to. And if they come crawling back to you like, I need help, help them, but don't rub it in like, I told you so. Just make sure that they're okay, but let them try and blossom as their own person.
Try to blossom as their own person. I like that. Yeah, and I'm so grateful to have you here, and also Ria too, just to kind of give, one perspective in the teenage years and in the young adult years. And of course, everybody's experience is unique. You don't have to represent all teenagers and all young adults today, but just to give that voice. And speaking of that, Ria, I'd love to ask you, as you've entered your teenage years, how have you taken more responsibility for caring for your epilepsy? For instance, do you take care of your medications or come up with questions for your doctors, setting good rhythms for sleep or working on stress, those kinds of things? As you've gotten older, how have you taken on more responsibility?
So as I've entered to be a teenager, I've taken more responsibility for caring for my epilepsy by telling my mom when my meds are almost done. I help her refill my med box. I take my medication on my own out of the day that matches with the day. I let my teacher, coaches, and students in my classes know about my seizures so they can be aware in case something happens. And I use coloring to help manage my stress levels.
Mm-hmm.
I also do yoga and deep breathing exercises. I listen to calming music to fall asleep.
I love those things. I think those are good examples of taking on that responsibility, and also encouragement for others to find what it is that helps them. So those are great examples. Thank you.
And I actually do cooking all the time too.
Yeah, sure. And of course, it's also important to ask for help when we need it. Olivia said that too. That's also part of responsibility. It's not that responsibility means you have to do everything yourself. So Ria, can you think of some ways you've asked for help when you've needed it, whether that's at home with your parents or at school or with your doctor? Oh, and Ria, you're muted. Let me see.
Sorry.
That's okay.
So I ask for help when I tell my parents, teachers, or other people that I'm with that I am feeling weird or different, like I'm about to have a seizure, so they can watch me and make sure I don't fall or hurt myself. Also, because of seizures, I sometimes have to miss school, and then I have to ask my teachers for extra help.
Yeah, yeah. And you do that so well. Just, having known you, I know that you take initiative, but you also ask for help when you need it. I think that's a good example. And by the way, that's a good example for adults too. Like we all need that. So thank you for that. Some really great answers there. And Olivia, I'm sure you connect to some of those things too, having been Ria's age, and of course, having grown older beyond that. Like, you've made that healthcare transition from pediatric epilepsy care to adult epilepsy care. I'm just curious, what was that like for you, and what sort of advice would you give teenagers or young adults, and also their family members, as they make that transition?
Well, so I made that transition relatively recently. I think because not only your parents, but your doctors as well sort of form this bond with you, and they're sort of like, oh, but I don't want to let this patient go. I've formed this bond. We talk about, like, one of my neurologists and my mom would start talking about how their sons were doing swimming, and oh yeah, we have to get up so early to do swim, and blah blah blah. And then I'm like, hey, I'm right here. Isn't the portion of this supposed to be about me and epilepsy and seizures? But that also shows how well, I've been treated, and I've become, sort of, I've gotten much better. And so they're just on the page of like, we're going to talk about swimming. But yeah, so the pediatric system was sort of holding on to me for a very long time. They're like, okay, well, I think finally we have to let you go at 22. We're going to have to let you go. And so, but there's a really good epileptologist at Michigan Medicine. And so he is now my epileptologist and is taking care of my DBS, my deep brain stimulator, and all of that. And I think that for me, it was relatively simple because it's going to the same place to a different person and just explaining, okay, this is my narrative of events, but you also have this entire sort of summary of Olivia Moses, X-year-old, has focal seizures originating in 2009, blah, 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 blah. So they have the whole rundown. I just have to have a simple, summary as well.
Yeah, you said something in there. I just want to pause for a moment that I really loved, because you were saying, like, yeah, they've got these medical records, but also I have a narrative, which is the empowerment, but also like this is Olivia, the person, and also that you're crafting that narrative, and we're all doing that all the time. And I really love that. And so that you get to weave that narrative of the person who's had that experience through, from pediatric care to adult care. I think that's really, really amazing. And alongside the medical pieces, during high school, you began to make plans for your next chapter in adulthood. And for you, that it turned out to going to college. And after your graduation from Michigan State University, you've started employment too. So I'm just wondering, what are some of the key considerations you made for your epilepsy as you entered young adulthood, and what was most helpful for you?
It's interesting because you turn 18 and you're like, well, now I have all of these legal things. Like, ooh, you get to do this, and this, and you can also go to prison as an adult. Like that. It helps that my mom is a legal aid lawyer, and so there was a very funny 18th birthday card with all of the things you get to do, and then
you're 18. Yeah, sure.
But yeah, it was interesting because I began to have to, show my ID. I had to start to fill my prescriptions on my own. Luckily, I have all of my prescriptions at CVS, and they're actually like, they recognize me, and it's sort of like okay, I can go on this app and I can fill, this is what I need, or they're on auto refill. So I go get my prescriptions. I pay with the Amex that my parents gave me when I was going into college, but I also have my own credit card because we established just my own singular, and this is going off of sort of, getting your own credit statement and all of that as a young adult. When I was going to college, I also went to the Michigan State University Federal Credit Union and made my own account that is not affiliated with my parents' account, unlike my credit union account here at Community Financial. So I have my own credit card as well. So I have my own credit statement, and it's good. I pay my credit card on time.
I love it.
Knock on wood. But it's basically these things that I would consider basic, but also in the long term, it's not necessarily basic. It's something that I needed to remember and have like, okay, this is going to, like, each month you need to pay this, or should I use my parents' credit, like the credit card that my parents will pay for this, or should I use my own credit card for this? And I got a job at my university, and so once I started getting my own pay, then I was like, okay, I'll just use my own credit card and build up my credit.
Yeah, I think what you're bringing home here is, I mean, really, and this is true for anybody who has a teenager, who has a young adult child, people who are teenagers, people who are young adults, like we're also just talking about like building adult skills, or as they say, adulting, all the multifaceted pieces that are social and financial and educational and goal oriented and hobbies and all sorts of things. And so, you all are great examples of people who are taking that initiative. And, actually, Ria, I want to come back to you, and then maybe another question for you, Olivia, too, because one thing we're seeing in the chat are folks who are saying, like, my teenager's listening right now, my young adult is listening right now and is glad to hear from you. So Ria, I wonder, what advice would you give teenagers, or maybe even young adults with epilepsy, as they consider what their own goals are? What advice would you give?
So if they had epilepsy, I would give them advice like, okay, they say, okay, I can't do this. I'm like, it's okay, make your own goal, see if you can do it. If you can't do it, that's okay, change your goal. Like how we do even in class all the time. Like we change our goal every week. And then I would say, I'll tell other teenagers with epilepsy that even though it sometimes seems hard, but you can do it, a lot of things, and you should follow your dreams. Don't let epilepsy stop you. There are a lot of people out there that can help you reach your goals, and there's so many other people also that's worse than epilepsy. So we are actually kind of more lucky that we only have epilepsy and we can make our own goals.
You can make your own goals, like you said, and you can change them. If something isn't working, you can change it. And also Ria was giving a note to eSmart as well, because which again, Russ helped develop too. And it was Russ's idea. So I want to give Russ that great credit too. And we're continuing it. And that sense of setting goals around self-management, around advocacy, around resilience, or just around taking care of health generally, it's really, really good. And Russ, I actually would like to come back to you also. We know transition planning should take place in the school setting itself, either as a formal process associated with the student's IEP or an informal process where students' post-secondary goals are discussed. So I'm wondering if you can address this and give some examples of the types of transition services that might help students with epilepsy move toward their goals after high school.
Sure. So really any student, whether you have a health condition or not, can get assistance with transition planning. And that includes college and employment planning. That can be from guidance counselors, teachers, or other school staff. So that's something that's available to any student. But for students with epilepsy or other disabilities or chronic health conditions, that's when some of the things that you talked about in our earlier session come into play, like a 504 plan. So students with a 504 can talk to their guidance counselors or other school staff specifically about how they're going to adapt or carry over those accommodations to potentially a post-secondary education setting. And then for those with an IEP, formal transition planning is actually a legal requirement of an IEP. And I think, unfortunately, a lot of parents aren't told about that by their schools. I mean, I remember working for the foundation, hearing a lot of parents say like, oh, transition planning, that's supposed to be part of my IEP. And their school had never really told them that. Or in some cases, their school had given them a transition plan rather than involve them in the transition planning process. So, for that to be successful, it really is important for the parent and the student to be actively involved in developing that plan. So that includes multiple transition assessments that take place at different ages. There's also the development of something called an educational development plan that starts in 7th grade. You'll develop these measurable post-secondary goals in the area of education, training, employment, and then also, if applicable, independent living. So those are all things that are specifically addressed in this transition plan. And then, of course, you're also going to identify what is the coursework or other additional services that are needed to reach those goals that you set. I think we also referenced this in the earlier session about the two pathways that are often presented of getting a diploma or getting a certificate of completion. And I would say that in most cases, a diploma is going to be probably the preferable route because a diploma has legal weight and it's relevant to employers and to colleges, whereas a certificate of completion really does not have any legal standing or specific value when it comes to employment or post-secondary education. So students can choose, if they choose to try and get their diploma, they can do that simply with the supports that are provided through their IEP. And many, if not most, kids with epilepsy who have an IEP are able to get that diploma just without any kind of specific modifications to the curriculum. But there's also something called a personal curriculum that people can use, which is kind of it allows for some modifications to the Michigan merit curriculum that's required for a diploma. So that's another thing you can ask about if you think your student may have some difficulties completing some of the coursework as is. Again, if and I believe someone mentioned this in the earlier session too, is that you can actually, you don't have to necessarily get your diploma at the end of your senior year. You can continue to receive services up until age 26 and continue to kind of simultaneously work on developing some of those independent living and vocational skills at the same time as you're working on the curriculum and working towards that diploma. So that is an option. For those students for whom it's just not feasible or not realistic to be able to meet the course requirements for a diploma, then a certificate of completion may be an option that you can consider. And then again, as I mentioned, you can continue to get services through your school district up until age 26. And that can, involve a wide range of activities focused on preparing you for either independent living, employment, or both.
Yeah, very, very good. And as you two just heard some of that, I mean, Olivia, I'd like to come to you. Did you feel when you were going through school that you were being set up well to figure out what was next and to move in that direction? What was helpful, and if anything wasn't helpful, what would you recommend?
So it's interesting. I was actually on the same panel at the first back to school gathering, and I was the teen on the panel, and I thought I was doing great because in 9th grade, everything went crazy with my depression and anxiety. And so I had been in all of these, higher smart kid classes. Not really like, it's multiple choice smart kid classes, not like just overall holistically smart. And so instead of being in honors English 10, I was in regular English 10. Instead of honors geometry, I was in geometry concepts and skills. And I hated myself for that. I really did. And I had suicidal ideation. And I had to go to the hospital multiple times when I was in high school. So when I did this 6 years ago, I was in a really great place that I had never really seen before in my life. And I had known since my junior year that I wanted to go to this residential college in the arts and humanities at Michigan State University. And the great thing about Michigan State University is that they have their own program for people with disabilities. And it's for any type of disability, learning, physical, hard of hearing, deaf. It's for anybody with a disability, any type of disability. So it really helped for me to know, like, even though I didn't really use any of that assistance, to know that I had that on a piece of paper to say, hey, look, I have this if I'm not feeling well, which I used on occasion. It really, really helped me. And it was sort of this comfort, being away from home, being by myself, or dealing with some person that didn't like me as a roommate for some reason because I was there.
It's hard, yeah.
Again, that's just regular drama for college. That's
part of college.
College is yeah. But
you've raised some really beautiful things here, to be able to know that you have that support. And that's a good point for anybody on this call. If you have a young adult that's going on to college or some other setting where there is a disability office, with services, like, it's good to get in touch with them to know what's possible. And as we've talked from the previous session too, those 504s from high school, just to give one example, can be adapted a bit and can follow into college if that is the route that they are taking. And Olivia too, I just want to honor you and celebrate you, both the you that has come through some of those challenges, but the you that was in that place of challenge, because sometimes I think our kids feel a lot of pressure, and we have so many messages that say, like, you're supposed to be at some level, and we decide what that is, and it can be even very arbitrary. And our worth just isn't tied to our grades or our ability to perform and be productive. We just have value because we are. And from that place, like, you are also doing really, really tremendous things. And so, and as Ria said, just students with epilepsy are capable of so much, so there's all this possibility for all of that capability, and there's no place you're supposed to reach to have made it. Like, everybody on this call has value and is on their way toward setting goals. So Ria, as you heard Russ talking about this kind of planning for vocational goals for what's next after high school, how are you being prepared? Do you feel like the school has raised those questions for you? And I know you're entering your last year of high school, so I'm sure this is on your mind.
So I've not had much experience with the transition planning, but I think and hope I will in 12th grade this year.
Yeah, absolutely. Yeah.
But I am going to graduate, and we're just going to try our hardest.
Yeah, it'll be a great celebratory moment when you get there, right? And just that we can always ask those questions. And that's another thing too, I would say, for any student with epilepsy, or really just any student or any person, like, it's okay to take time off too, if that's something that you need. There's no like timeline of where you're supposed to be at a certain age. You said it best, Ria, like, our goals are shifting all the time. We can shift them as we feel we need to.
Yeah, even in school, I make my own goals. I change them every minute. I'm like, okay, I just need to change my goal. Then I change it. I'm like, can I do this one? Okay, I try it. It's getting too hard. Then I change it, and then I can do it.
Yeah, trying it and shifting it, and that's something we do as adults all the time too. We have to do that.
It's normal.
Yeah. So you're getting good practice. It's good. Russ, if teenagers or young adults are looking for employment after high school, are there some organizations that help with job training, matching, or is there anything else you might recommend?
Yeah, absolutely. Probably the primary one that comes to mind is Michigan Rehabilitation Services. And they are the state's vocational rehab agency, and they help not only adults to find employment, adults with disabilities to find employment, but also they work with the Department of Education and local school districts to provide these pre-employment transition services for teens. And that includes job exploration, work-based learning, counseling, and on post-secondary education, workplace readiness training, and then self-advocacy training. And I know that was mentioned earlier too, this idea of advocating for yourself and being able to express your needs, being able to ask for help. Those things are also very important. And for young adults who stay in the school system up until age 26, that level of service is even more intensive, and so there's more intensive job planning and training services that are offered, and it's of course tailored to individual needs. For those who have specific employment goals, they may get certain services. For those who are maybe more focused on developing independent living skills, that they can be tailored to that goal. There's also something called the Michigan Career and Technical Institute, or MCTI. And this offers post-secondary vocational and technical training in kind of a college environment. There's dorms, there's off-campus housing, but they have 13 specific training programs that you can focus on. That includes things like culinary arts, landscaping, you can be a nursing assistant or a pharmacy technician, automotive technology, information technology, just to name a few. So that is something, if you should decide that maybe college is not the right route, but you want to still get some training towards employment, the Michigan Career and Technical Institute is definitely something to consider. And I believe in many cases that there's, maybe I shouldn't say anything on this because I'm not sure. I don't think there's a cost to it, or at least they can provide significant financial assistance with that. So
that's great. And Shannon just put that link in the chat as well. And that's something I just learned about today, thanks to you. I didn't know that existed. So that is really, really exciting. I do want to say to everyone, if you have questions for our panelists, feel free to put those in the Q&A feature. We have some questions that we'll get to in just a moment. But I would like to ask Olivia and Ria too, recognizing that goals shift all the time. What are some of your goals? What are you working toward? Like what are some things you're doing? Who do you want to be when you grow up? How about you, Olivia? Do you want to go first? Or still thinking, Ria? Anybody?
So I want to be different things. We're not 100% sure yet, but my choices are teacher, a vet, maybe a nurse, maybe just a babysitter, or maybe I'll work at a restaurant. There's different
Yeah, so many options,
There's so many things, but mainly I want to be a teacher or I want to be a vet.
Oh, that is so cool.
Because I love little kids and I love animals.
I love that. Olivia, how about you?
I've already gone through undergraduate college, and I have a part-time job, but I still don't really know. I think I've come to the conclusion that there's probably going to be around 6 different jobs that I'll have in my life, and I will see what comes to me, what I go for. But right now I have the Epilepsy Foundation to help out. I have the American Citizens for Justice movement to try and hone in. I have a lot of other things that I love as well. So I'm just living life day by day right now.
And you know what? I think so many of us are at any age, doing exactly that. And we've lived a strange few years here with the pandemic as well. And I think some of my advice for young people is just, sometimes you find that great place of meaning in your work. Sometimes you just find something that helps support you so that you can do, that other calling or that sense of meaning that you are putting into the world, right? It's not always in the job. Sometimes it is, but there are so many different things we can do and so many directions we take, whether that's hobbies or work or community involvement we do. Russ, I would love if you would tell everybody what you're doing while you continue to grow up, and if you would tell us a little bit about your new position and what you're doing there.
Oh yeah, that I was just going to say to Olivia, yeah, I still don't know what I want to be when I grow up. So it's a you mentioned 6 different jobs. So I think I've only had 3 jobs since I left grad school. So who knows, there may be, I don't know what my future holds, but in any case, it's I think just being open-minded and flexible and as new opportunities come about, you can explore those opportunities and I think a key element is finding something that interests you. A lot of people say finding your passion. You don't necessarily have to be passionate about it, but you have to, if you can find something that you really enjoy and that gives you some meaning and purpose, I think that's one of the most important things. If you can find that in your job, that's it's gold. I mean, that's amazing if you can do that. So, and there's a spectrum of things too. Like if, Ria mentioned wanting to be a vet, but there's a whole spectrum of things in working with animals. You could be a veterinary assistant, you could be a vet, you could be, you could work at a zoo, you could, it's finding that interest and the types of skills that you are, and the strengths that you have, and finding a way to incorporate that into your work. And again, the more open-minded you can be, the more options you'll have. And I think that's, kind of what led me to what I'm doing now, is just being open-minded and saying, yeah, I've been with the foundation for 21 years. Let's try something new. So, and I'm still getting to work with epilepsy, which is, a big passion of mine. And so yeah, I think just being open to different paths that may present themselves.
Exactly. Yeah. So yeah, grateful for that. And thanks for giving us a little bit out of that update with you too. So let's get to everyone else's questions. We've got some good Q&A here, and a reminder to anyone, you can continue to put questions in the Q&A feature. So let's start with this one. This is kind of going back to Dr. Cook's presentation this morning, but as an adult, is the shared decision-making approach still possible? What would you say, Russ?
It absolutely should be, but like, as I was referencing earlier, it's maybe not quite as inherent a part of adult care as it is in pediatric care. So it's something that I think, again, this was also mentioned earlier. It's okay to with a new provider, like let's say you've switched from that pediatric neurologist to an adult neurologist, up front to say, this is what I'm hoping, this is how I want things to work. I want to be a partner in my care. I want to, here are my priorities, like letting them know, like, maybe seizure freedom. A lot of times physicians may assume seizure freedom is your number one goal. For some people, it may not be. Your number one goal may be quality of life. And if that includes seizure freedom, great. But if part of that is, minimal side effects, or being able to feel as sharp cognitively as you can, that those may be more, take precedence over seizure freedom. So just making those preferences known up front and is really important. And I forget what the original question was.
No, you answered it perfectly.
Yeah, okay.
Just about the shared decision approach, and
right.
And that, yeah, I mean, any of us as adults can go in and ask for that and share that that's important to us, and that we want to be a partner in our care and our decision making. So, a question for Ria and Olivia. Have you had moments when it was challenging to develop friendships and find people who could understand your epilepsy? Have you had moments where that was challenging, and have you had moments where that really worked well, and what helped it work well? Or maybe another way to say this is, how do you make friendships, and how do you share about your epilepsy as you choose to do so?
I can go first,
Sure.
because I'm very upfront about my epilepsy. Probably I should tone it down a bit, but I think that if someone really wants to be my friend, they also need to tolerate that I have epilepsy, and that I'm going to be talking about it and saying, oh, sorry, I need to record this, or saying, I'm not feeling great, I can't participate in that. And so I have a small group of friends. I'm like my mom. She's also not antisocial, but not extremely social, not extroverted like my dad is. So I have a small group of friends that know I have epilepsy, know that they don't have to really take care of me for it because my seizures are under control, and my focal seizures are focal aware seizures. So I'm like, I could have one right now and no one would notice because I'd be talking and interacting with you. So yeah, that it's the kind of thing where, yeah, accept me for who I am, or bye.
I hear you. And you've also made a good point. I mean, it's the quality of friendships that matters more than the amount. And I think you've found your people, and I think that's a wonderful thing. Ria, how about you? How do you go about making friendships and talking about epilepsy and all of that?
So I have a small group of friends also. I told them, okay, I have epilepsy. Sometimes I might be acting weird because I'm getting into a seizure. You just have to tell the teacher if they're there, or tell any adult there, so we can figure out what to do at that time. But it is also hard for me to not spend time with my friends that much because of my epilepsy. I need someone there at all times, like that knows how to control my seizures, and that'd probably be my mom, or mostly my mom. And then she's busy, or someone else is busy, or we're just making food at home, so I don't have that much time to spend time and just with my friends and do sleepovers and those kind of stuff. But I just spend time at home and just do my fun stuff there, and with my cousins and spend time. I can sleep over there sometimes, but I do.
Built-in friends into life. Yeah. That's a really great point. And any of you can speak to this, but maybe Russ in particular, any advice for students applying for college, out of state or even further away? What sort of considerations might those students and also those families think about when it comes to epilepsy?
Well, I mentioned this earlier, that one of the key decisions is, are you going to try and find a neurologist in that out-of-state college location, or are you going to take trips back? A lot of that depends on how frequently you see your neurologist. If it's twice a year, then you may decide to just stick with the neurologist that you had as a child. And again, that's another thing to consider too, is different health systems have different ages to which they see pediatric patients. At Michigan Medicine, it's up to age 21. Some other places it may be 18. Some places maybe even beyond 21. So that's one of the things you want to consider. Also considering transportation, like when you go to a college, most college campuses don't have very good transportation systems, so you don't need a car when you go. So that would be something, but you'd have to think about things about finding a local pharmacy, finding, if you're going out of state, is there an epilepsy foundation in that state that you can connect with? So those are just a few things that jump to mind. But Olivia, I know you didn't go too far away, but it was a different city, I believe. So what were some of the things that you had to consider when there was some distance between you and your parents?
I think I was at a relatively, again, I was at a relatively good place when it came to my epilepsy. So it was more so me worrying about being out of state. Because my dad's like, oh, you should go to Claremont like I did. I'm like, no. And I think now that I look back at it, I was also not realizing my full potential as well. So I didn't apply to many colleges at all. I applied to 3 colleges. One was Scripps, which is part of a private college, the Claremont colleges in Southern California. And then I applied to U of M Dearborn, and I applied to Michigan State University in the residential college in the arts and humanities. So that's what I majored in. And I think I wanted to be close to my medical facilities. I didn't want like there to be an issue and then have to go on a medical helicopter thing, and because in the past I've had seizures and grand mal seizures where they had to take me from, the closest hospital to Ann Arbor. So I think it was my own sort of
Sure.
insecurity.
Well, lots to consider there. And I mean, I think that those are valid questions. And I just want to thank the three of you so much. You have given such good perspective. Russ, Olivia, and Ria. I would invite everyone in the chat to say thank you. Truly, thank you for sharing from the heart, from what you are experiencing and the transitions that you're in right now. So we thank you for that. Speaking of transition, it's time for us to go to another session. Very excited to have you all here. I'd love to give a warm welcome to Dwight L. Wilson, a mentor, educator, author, former headmaster at the Friends School in Detroit, and also Nicole Fitzpatrick, who is a parent coordinator at the Michigan Public Health Institute. And today they're going to be speaking with us about addressing bullying and fostering mental health. Such an important topic. We do believe this is a vital conversation for our community, and we want to welcome you all to this time of learning. And for everyone else, I again want to recognize and honor this can be a difficult topic. If this is something you've experienced in your life or in the life of your family, it can bring up memories, emotions, and concerns. So I encourage everyone in our audience to just hold this space well, and most of all, hold yourselves gently within that. If you need to take breaks, feel free to do that. And just know we're going to be discussing how people can get help, how they can address these things, how they can have community care around these kinds of experiences. So a big warm welcome to Dwight and Nicole. Welcome here. And I'm also wondering if the two of you could introduce yourselves and share just a bit about your interest and your experience with this topic. Dwight, could we start with you?
Yes. Can you hear the fan that's behind me? It's 98 degrees. Good.
You're good.
We're out in Kansas visiting our grandchildren, our granddaughters. I have 4 biological sons and 2 bonus sons and a bonus daughter from my wife's first marriage. And we have 5 grandchildren. I spent 41 years as an educator, but I've also been in the ministry since 1966. So they have been parallel pieces of my life. I retired officially the first time in 2009. My wife says that I passed her on Facebook, but she was not the first person to notice that, and which is very true. So if you don't let go of my hand, I don't let go of yours. And I have somewhere around 2,000 people who I stay in contact with. Some monthly, some every other month, some every 3 months, some every 4, some every 6, and some on their birthdays. And when I say I stay in touch with them, I keep a record of the day that I reached out, but I don't keep records of the day that they did. I just want them to know that I'm here. And there are several people who I stay in contact with and love. To me, anything that is not done as an act of love is an intrusion. Sometimes I'll only say, I'm still here. And I haven't heard from them in a year or 2 years. And then they'll get back to me and say, well, I was dealing with some mental illness, and I just can't respond all the time. I just want them to know they're not alone.
it means the world, and I think that is the kind of culture and larger community we need to build in order to even address bullying, right? I mean, we have to surround each other, and that's a good example of that. Nicole, how about you?
Hi, yes, thank you so much for the opportunity to speak on this topic today, near and dear to my heart. I am the mother of a blended family of 5, and our youngest is now 17, turning 18, and embarking on her college journey. So there's a lot to that. But in the start of our journey, she was 7 when she was diagnosed with epilepsy, and she was in 2nd grade and did deal with a lot of bullying and isolation and things related to that throughout her elementary years. So this is definitely a topic near and dear to my heart.
Yeah,
So thank you again.
Yeah, absolutely. And I know in unique ways, both of you have participated in educating others, and you're both parents, you're both mentors. And I'm curious if you could share how you've used these roles to address bullying and how have you chosen to address it? Nicole, would you mind answering that first?
Sure. Yeah, of course. So when she was diagnosed, first in 2nd grade, like I mentioned, we were very open in reaching out to the school and to the other parents first, and then to the children. And that still did not prevent the bullying that came about afterwards, unfortunately. But we persisted in that open communication and that open dialogue and tried to use some different tactics as far as working with the school again, working with the counselors, directly working with individual parents to try and build that allyship and those relationships to help foster that support for her. Yeah, so those were some of the key things that we did throughout her elementary years, of really that reaching out and trying to just build that advocacy and that support with those other families in that community, in that space, to give her a friend and that support. Interestingly enough, because of her role, she was the one, when she would see other kids being bullied, she would step in. So yeah, and I know we'll talk a little bit about the individuals and the children a little bit later, but those are some things that we actively did. I don't know how much of an impact they had for her, unfortunately, but I think hopefully for those that followed, maybe there was a better success rate.
Thank you so much, Nicole. That's such a good point too. It's like we want to make that change for our own kids, and hopefully we can. But also that change, can exist well beyond even them being there, just because we stepped in. And thank you for doing that, Nicole. And Dwight, how about you? Just various roles you've played. How have you chosen to address bullying? How have you seen that emerge in some of the roles you've had over the years?
Okay. I spent, in my career, I spent probably about 20 years as the person in charge of discipline. That's from university to boarding schools, day schools, and when I retired, I was the head of a school that went from 3 years old up to 8th grade. I speak about celebrating discipline. By that, I mean, I'm a writer, and if I don't discipline myself to have time to write, then I don't write. I'm not talking about punishment. Too often we look at discipline as being punishing people. What I believe in is creating a culture where love is centered, and you don't need to worry about corrective discipline because you prevented a need for it. You've made an atmosphere where love and compassion can be celebrated. So I see bullying as being the act of quieting or silencing the words or actions of another person, while simultaneously inflating one's own importance. With that definition, I can think of any number of people who are bullying. Somebody who is a bigger or better fighter. That's what we usually think of. Someone who shouts over another person. But I used to tell teachers who worked under me, because I was also at one point the dean of faculty as well as the head of schools. How about a teacher who calls only on certain students? that teacher is participating in bullying those who are quieter, those who aren't saying me, trying to answer every question even before they've heard the question, they've got their hands up. And then somebody else who is not as assertive, she or he is sitting in the background. And I have discovered that many of those students who are in the background, who don't raise their hands, who are not as assertive as other people, have a great deal to contribute to the community. So one of the things that I did when I was in the classroom is we sat in a circle. And I would ask a question, and you could pass if you wanted to. And then from then on, we'd go clockwise. And anyone who wanted to pass could do it. So often, educators will only give 3 seconds for an answer, but I'm a Quaker, and I can sit in silence for an hour. So giving people the space to share what they have to share not only gives them face, if you know that phrase, but it also helps them understand that you don't have to be that loud talking person. And it helps a teacher understand that if you participate in silencing another person's voice, you might not want to think of it as such, but what you're doing is you're bullying them.
Thank you.
So,
well, I mean, I love what you said about creating that culture. And I think having that modeled creates something, right? I mean, that's just so vital. Parents can do that. Students can do that. Of course, teachers and administrators can do that. And speaking of that, I mean, any single person can create or can play a crucial role in addressing bullying, you know, whether that's being an interrupter or creating that different culture. And sometimes we may need to be the one to step up and protect someone. And that being said, it often takes a team approach as well to address bullying and care for a child after it has happened. So Dwight, how do you recommend, you know, that stepping up, and how do you recommend building that team?
Well, we were at dinner yesterday, and we're visiting out here in Kansas, where my son is a middle school teacher, and he is a serious advocate for anti-bullying. If you ever have another session like this, getting him on there would be a great thing for you to do.
Right.
But his wife said to me, I can't see you as being a principal. And I said, you know, it's funny you said that, because I used to tell the students I'm a prince who is a pal. That's how I break it down. So what you try to do is be somebody's friend, no matter how high the position or how low the position is. And if you can be a voice of support, you can help other people see, wow, that's a good thing. Why can't I do that? Because you automatically feel better about yourself when you are supporting someone else. So many times we'll pass by a person because we don't know how to be helpful to them, or we don't want to get involved. Sometimes all you need to do is just sit down and be there and just touch their hand or touch their elbow before you leave. And that alone can make the situation so much better. You don't have to have any magic words. All you have to do is use the heart that we were given at birth. I hold babies in a pediatric cardiology ward of Mott Hospital, Children's Hospital. I've been doing it since January 2011, every Monday morning. Those babies understand love. What they don't understand is all of the artificial divisions we have between us, race and gender and sexual persuasion and what body disability one may have. They understand love. And I think if we go back to our natural state, we all understand what it means to be a loving person, a kind person to other people. And that has nothing to do with being soft. As a matter of fact, I think it's harder to be loving than it is to be mean.
Thank you for that. Such wisdom there. I appreciate it. Nicole, what would you add? I mean, like, how do we step up? How do we be that person in the moment? But also, how do we build a team in caring for a child that's going through bullying? You know, what would you suggest?
Yeah, I think, again, that community, building that community in that space. One of the things I've looked at more recently now is what is being done in our system, in our educational system today, and to address some of those things, to address some of those gaps. And looking at how do we expand on that? How do we move that out? I did find there are a number of resources that are being done in our school district that I was not aware of. And I'm not sure that they're being done consistently across the board, but that's a question I can ask, right? I can go back and say, how are we making sure that this is being presented and then lived out? And then being a good role model, like you said, Dwight, we can all model this behavior, right? This is such a time of divisiveness, and we really need to come together and model that behavior of kindness and support and be that person that invites others in. And also, I think it's so important to think about, we just have a culture of, it's an instinct, I think, primarily part of our makeup is looking for things that are similar to us, that make us comfortable, that make us feel normal, that make us feel safe. And it takes strength to go out and find and accept others that are different. So I think bringing in people into your life who are different in many different ways, I think that's so important to broaden our horizons. And then by doing that, I think we're going to have a better culture of acceptance for all. So yeah, I think modeling those behaviors and being the one to step up and speak out. I'm so excited about some of the work we're doing at MPHI in training and preparing parents and people who want to step up and step into that advocacy role and helping them find space to do that. So I think that those are things that we really need to focus on as parents, as advocates, just as a community as a whole.
Yeah, wow. I'm really touched by your all's answers. And I think this is one of the things that has gotten me so energized in this community, is thinking about disability culture, and anybody can do a little Googling of that. What is going on with that? What do we mean by that? And like, I know here, sorry, I say here because I'm in Ann Arbor, but there are students with disabilities that are trying to create a disability cultural center. And that you build this culture of honoring people's needs, of knowing that it's okay to have needs. You know, we do so much in our life to try to hide that or bury that so that nobody sees what we need. But that sense of knowing that we all have needs and we can all provide toward each other's needs, and also that we can build a whole culture around that, accepting difference and in fact honoring it, is a really, really beautiful thing. In the midst of that, you know, it's really trying to be anti-ableist in a lot of ways too, but we know people with epilepsy do sometimes face stigma or isolation, and this can be true for children or teens in school settings. So what are some strategies to reduce stigma for students with epilepsy, or any child that has chronic illness or disabilities? I wonder, Nicole, do you want to speak to that?
Sure. So for the stigma portion of it, I think it's the normalizing. And that's one of the reasons I'm so excited about the seizure safety schools. I mean, I think it's a matter of education, awareness, and normalizing epilepsy and seizures, right? There's so much information out there. What do you do if someone's having a stroke? Well, there's a critical health situation that's going to look physically very different if somebody's experiencing a stroke, but people aren't scared of it. But because we don't talk about seizures, because it's had that stigma and it's been in the, so to speak, closet, that people haven't come out to say that I have seizures, that I have epilepsy, because they're afraid of that stigma and that isolation. Stepping into that. So I'm so excited to see the young people talking today about, I'm very, being an advocate about that. I was so proud of my daughter when she put on her profile for finding a roommate that she has epilepsy. So that was out there for anyone to see. I was, speaking and stepping into that space and not being afraid, so that they feel loved and supported to do that. I think normalizing is going to be a big part of that. And that's what we tried to do when she was younger, of, making that awareness, like, this is what's going to happen. This is what it could look like. And here's what you do. I think that's going to be a big step as we start to move forward. And I hope that that passes, and that will be a big step forward, I think, in erasing some of that stigma.
I agree. Beautiful. And Dwight, anything you'd add to that?
Yes, Renee, both you and Nicole spoke about culture, which was the next point that I had made in my notes. Because we live in a culture that shames people because of their race or a profile that doesn't fit what people consider to be the norm. One of my great blessings, I surely did not see it as a blessing when I was growing up, was being a Black man with freckles, or at that time being a Black boy with freckles, because people made all manner of mean statements about the freckles. And I was ridiculed, but even by relatives who were close to me. And it was so hurtful, but it helped me understand how to be empathetic to other folk who are put in a situation where somebody's got in their mind some stereotype of what you ought to be. And 99.9% of the time, it's exactly like them. Well, I always knew you weren't going to be a Black man with freckles, so I didn't have to worry about you being exactly like me. So how can I help be more sensitive to other people? I had put in the chat earlier, because I came on about 14 minutes after the hour, 12 minutes after the hour, that if you go away to school, one of the first things you should do is sit down with the dean of students and the dorm parent and explain to them together that you have epilepsy and what that means, because I'm certain that one size does not fit all, just so they can be tender. I remember one of my former students who had an epileptic episode, and I didn't know, and I was the dean. I didn't know that she had epilepsy. And she was at a play rehearsal, and somebody rushed down to my office to tell me that she was having an episode. And obviously, I rushed there too, but by the time I got there, the emergency service had come and had taken her away. I don't even think, I can't remember if I even saw her. Now, I'm still close to her. I left that school in 1982. Okay, 89. So if I had been aware that she had that in her background, at least I could have been sensitive to it. But as it was, nobody knew. In my family, I don't know of anyone who has epilepsy, but I know of many people who have depressions, who suffer from depressions. And some of them, including one of my sons, I didn't know it until he was like 20 something. And he was diagnosed with it. I wasn't shocked because my mother did. I have two siblings who do. I had a grandfather who did. I didn't know it. And trying to help him understand that this is a part of who he is. This is a part of his identity. Even as 24/7, 365 in leap year, 365 days, I have allergies that causes me to have to take medication twice in a day. I just had to do it. So it doesn't reduce my value to society. And it doesn't reduce someone's value to society if they have epilepsy or autism or suffer from depression. It's just a part of who you are. You carry yourself with the greatness that was intended. And each one of us was intended to be a great person. Don't let anybody reduce your value. And that's one of the things I try to help teachers understand as well. You know, you don't just play to the brightest students in the class. You don't just play to those who think like you do. If you don't love all of them, regardless of who they are, then you couldn't work for me. And I was not going to renew your contract. And there are two people I love dearly, but they didn't love everybody. So they didn't come back the next year. Sorry.
It's back to that building of culture, right? I mean, it's just vital. It's vital. Yeah. I mean, thank you for all of that, both of you. And Dwight, how can parents be intentional about building up a child's self-esteem, particularly if they have some kind of difference, and we all do, but some might be more visible than others, or if they feel uneasy in social settings? How can parents really be building up that child?
Well, you all should know that Renee has daughter status in my family.
I do.
I had 4 consecutive sons, and I wanted a daughter every time. And my boys know that. I wouldn't trade either one of them for a daughter, but I found other ways to do it. So my other way of doing it is adopting former students as daughters. And so one day Renee says to me, I said, I think I probably have about 10 or 12 daughters. And Renee said, you got at least 30. And so I counted them for the first time. It's over 60. So how do you build up someone's self-esteem? My mother showed me how to do that when I was 6 years old. So I'm in first grade, and my mother taught me how to read when I was 3 years old. When I got to first grade, I was reading on the 5th grade level. So I'm way ahead of the other students, not because I have some superpower gift, but because she spent all that time with me. So I whispered to my teacher, who happened to be, consider herself to be a white woman, Andrea is my girlfriend. And Andrea was this little girl who sat in front of me, and she looked like a little Shirley Temple doll baby type. And the teacher said in her loudest voice, so the whole class could hear, Andrea cannot be your girlfriend because she is white and you are a Negro, which is a word that they use at that time. And I was nonplussed because I was taught first that the teacher is always right. And second, that Negro was a good word. My father had told me, if somebody calls you the N word, I don't need to say that, you know which word I'm talking about. Say, I'm not an N, I'm a Negro. When I become an N, I'll let you know. And my father was darker than my freckles. My mother's about the color of the palm of my hand. And I told Mom what had happened when she asked me what happened, what went on in school. And I told her, and she took my hand and she looked in my eyes and she said, never forget, you are as good as anybody. I'm 6 years old. If my mother had told me the sky was green and had orange polka dots, I would have believed her. She empowered me. She empowered me for the rest of my life. And I can go into any space. I've been to the White House 2 times. I live in a town where almost everybody has at least 2 degrees, if not 3, if not 4. My wife has 5. I never feel as though I am inferior in any space because my mother empowered me. So I say all of that to say that a parent who loves her child or his child can empower that child by telling them, you are beautiful in yourself. Your essence is as good as it gets. And by doing that, you can be around any of my grandchildren, which it blows me. Now I'm prejudiced, you know that. But it blows me away that all 5 of them are nice. Are nice people. And they all 5 have self-confidence. I asked one of my oldest granddaughter, she's 6 yesterday. I said, you're pretty, do you know that? And she said, I know it. So, wow, you do? Okay. And I said, and you're bright. Do you know? Yes, I know I'm bright. It's like, yeah, teach them, teach them,
Teach them,
teach them to be beautiful.
That is beautiful. I so appreciate that. That's gorgeous and true. And Nicole, if a parent or caregiver feels that their student may need some professional resources, say like a therapist or maybe something else, to address that bullying or to strengthen their mental health generally, how might they go about that?
Yeah, so we did do that when she was in her late in her elementary years. I think it might have been like 4th or 5th grade. My concern was that wanting to make sure that her sense of self was solid enough to withstand what was going on around her. And so we reached out. I was very laser focused on what I wanted was a mental health professional who was dealing with or experienced in dealing with chronic health patients, youth. And there isn't a wide variety of them available. I think, if I had just been more open to maybe just in general, going to your pediatrician, that using your resources, going to her neurologist, those people can help refer. But I was very laser focused. I did find a person who was focused in the area of chronic health for children here in the Lansing area where I live. And I did take her there. And I'm glad that I did. People around me, because if you asked my daughter in that period of time, do you like yourself? Which, how do you feel about she'd say yes. But then she'd also cry at night about the kids not liking her. And, we talked about switching schools and she was mortified and they're not going to like me either. And so you knew that there was some impact going on, right? And she was trying to sort through all of that. So I did get her to a therapist and she did work with her and talk with her and gave an evaluation and said that she was centered, that she was dealing with some issues, but that she seemed to have that center, which again, I was very adamant about. You have epilepsy, epilepsy doesn't have you. There are things you can do, there are things you can't do, but there's more you can do. So let's keep, moving forward in that regard. Yeah, thank you. And for people that were mean to her, we talked about what's going on in their lives. Talking about the bully and what's going on there with the bully. A lot of times it's a point of insecurity for them. And so they're seeking out, again, to isolate so they can feel better about themselves or to put somebody else down so they can feel better about themselves. And talked about the fact that that's unfortunate. And, the unfortunate nature or situation is that's happening everywhere. It isn't just with our kids. It isn't just in this chronic world, right? It's everywhere in our society. And so when you see other parents who are, in a small group and bad mouthing other parents, your child sees that and they see you see that and they see what you do about that. So if you step in and say, hey, this isn't cool or this isn't kind, or that helps them to then learn to do that on their own. So I think that those were some things that we did. Did I answer the question? I think I got lost, but yeah, those are just some things. And I did want to mention too, the education part of it. And I cannot thank the foundation enough for all that you guys have done, because the education for me as a parent in taking like the seizure safety and the seizure training program, and the fact that you go out to schools and you offer that, because I know when I started working with her school, they did not know. They did not have that training. There was no awareness. We had a situation where we had told the school, now she's in high school, fast forward years, and she's in high school and she's got a 504, and we've told the school, and I communicate with all of her teachers, and she had a seizure in class. And I know I've shared this with you before, Renee, that she had a seizure in class, in her psychology class, and she's in the front row. And the teacher just sat and watched it happen. And the whole class just sat and watched it happen. Now she has tonic-clonic, so she had no memory of it happening. She did remember that she didn't feel right when she started to come out of it, and she wasn't sure, but nobody was like close to her. Nobody gave an indication that anything had happened. So she just sat there quietly. And then when class got over, she got up to go to her next class. And the teacher said, Mackenzie, I think you need to go to the office because I think you had a seizure during class. And she was mortified. So then he sent her wandering the halls to find her way to the office. So education is definitely needed. And I had quite the conversation with the school after that. And, you know, part of it is they're strapped, right? Part of it is their resources are strapped. But not only did they not deal with my daughter appropriately, they taught a classroom full of individuals how to deal and respond to somebody in that situation. Yeah. And that's not acceptable to me. And my initiative to continue to pursue this within the school, even though she's moved on, is very strong.
I need to say something behind what Nicole just said. So I'm headmaster principal of a private school, and the chair of the board and the outgoing chair of the board and the incoming chair of the board were in my office when a parent stuck her head in the door and cursed me out. She called me everything but a child of God. So when she left, the incoming chair said, "You let her talk to you that way?" I said, "Yeah," and she was right. Because what they had done was they had told me anybody who was behind in payment, they had until Thursday to catch up. Well, she didn't get paid until Friday. And she said, "My child has been here for, by that time, I think 6, 7 years. And you're going to tell me that you're going to put my child out." And I said to them, "I told you before that we need to treat people justly. We didn't treat them justly." And she was protecting her child. And no parent has any greater responsibility than to protect her or his child. So be assertive when people are mistreating your child. Now, I'm not going to say that all principals are going to laugh at it as I did. I didn't laugh with her in the room, but I wasn't hurt. I was cheering her for doing it. Because this is your baby. I mean, this is why you're on this planet. So I'm begging those of you who are parents, call people on it when they don't treat your children well. And if you are not a parent, if you have a friend who is being mistreated, do the same thing. I used to hold every single year what I called it Envisioning a Better World conference. And I would have the students do all the planning, and they would envision how the world ought to look. And no adult was allowed to even speak. And it'd be a 6-hour conference. Well, students know how the world ought to look. And they can see those kids who were in that class when Nicole's daughter was not being treated properly by the teacher. Now, they may not have known that minute, but I bet you they know now. And they look back and said, well, we could have done things better. There could have been love in this situation. Now, for us to do that, we have to learn how to embrace inclusion. We have to learn how to embrace people who are not like us. We have to look beyond putting ourselves in a position where we think that we are superior to someone because of our race or our gender or our grades or whatever. We have to learn how to love all people. And if we can do that, we can prevent the need for people to try to find a sanctuary. Yeah. Because they won't need to run to something. They will already have beauty surrounding them. That's what our calling is as human beings, is to make a community, what I call a common unity. I put myself into a common pool where love is a way of going forward. Anyway.
That's good.
Excuse my passion. I'm sorry.
No, I'm not. You are not excused. I do not excuse your passion.
So back to, the whole like finding a place for them to talk and someone to talk to. I think that's so important, and learning those life skills of how to manage through. I think we all need to be taught those life skills in schools. But yeah, so she did find another therapist later that helped her learn to cope with her anxiety and her stress of things. And so it's beautiful because, again, I'm seeing those skills come into play now as she's stepping into a whole new space. And she said to me, Mom, I get to reset. Like, nobody knows me. Nobody knows that history. And she put it out there. She has epilepsy. So she's not afraid of the epilepsy. And she put it out there, and she's stepping into her own power and her own space. And I just could not be prouder. But it doesn't happen overnight, and it takes a village. It takes that community. And yeah.
Yeah. And we're so glad. I also want to speak on behalf of the foundation that we're so grateful for the ways that people invite us into their lives. And going back to that seizure first aid training, yes, absolutely. That is one of the things we provide and absolutely want to provide. So for anyone here, if you are needing that kind of training for your teachers, the educators, administrators, we can do that. And we can do that in an individualized basis. We can do it live. I mean, there's also on-demand training that the Epilepsy Foundation of America provides. It's a 90-minute training so that, educators can go in there and do it as on their own time as they need to do that. That's another possibility. And you're right. It's about educating people first and foremost how to care with first aid and how to recognize a seizure, but it is just as much to build that compassion and to say, hey, 1 in 10 people will have a seizure at some point in their lives. 1 in 26 people will have a diagnosis of epilepsy at some point in their lives. So even when anytime you're in a large gathering, there are people with epilepsy in that gathering.
Wow.
How many groups of 26 people do we know?
Yeah.
A lot. So that's what we are here for. And yeah, it's important. So thank you. I want to ask you another question, Dwight, too. If parents or caregivers feel that teachers or administrators are not taking a child's experience of bullying seriously enough, do you have some advice about how to open the lines of communication or effectively shift that dynamic?
Yes. Ask for a meeting. And when you ask for that meeting, go with somebody else.
Mm.
And if you want to make sure you get the meeting, when you send the email asking for it, copy another person, not blind copy another person. So they know that at least 2 other people are looking at this, therefore is going to encourage them to listen to you. A lot of parents have told me, not in any school that I led or was deaned to, that they couldn't even get a meeting. Well, you can get a meeting if you strategize. You make sure that there are multiple people on that request.
Mm-hmm.
And when you go in, and I'm a 2-time cancer survivor. Both times when I've had cancer and I've seen umpteen doctors, I don't even know how many, my wife always goes with me as an advocate, because sometimes I'll hear things and they may not register, or it's so close to my heart that I don't hear them correctly. So you've got this second person in. It might be your mother, your sister, your brother. It doesn't need to be an attorney, please. A neighbor, just 2 of you there trying to help somebody understand, this is my child. She or he needs this, that, or the other. And how can you help us move from point A to point B?
Yeah, very good. Thank you. Very good. It's just good practical advice, which I know sometimes people need, especially when they're right in the midst of this. Nicole, how can neurologists, epileptologists, and other medical professionals be helpful when a child is experiencing bullying?
I think the referral process, for sure. I think it also helps when their experience is validated by the professionals. So when you're in with the doctor and you're talking about, if you can get them, depending on the child's ability and their their willingness and their comfort level, right? We don't want to traumatize them further by making them uncomfortable. But if you're able to have that conversation with the neurologist, the pediatrician, with the child there, and let them give voice to their experience and then have that validated by that professional, that again helps with that esteem, right? That you're saying this is happening to me, and it's not like you don't believe them. Oh, that's just so and so and they're just being funny, or if you can't, you have to validate what that experience is for that individual, and there's growth in that. I think that's probably one of the biggest things that I can think of.
Yeah, very good. Very good. Appreciate that. Anything you want to add, Dwight?
Yeah, I've never had to meet with a medical professional over this issue. But I do remember a time, one of the things I used to do to empower students was every Monday afternoon at lunchtime, I would meet with the student leaders. 5 from the 8th grade, 3 from the 7th grade. We're talking about middle schoolers now. And they would be selected by their peers. Couldn't be more than 3 of any gender in the 8th, couldn't be more than 2 of any gender in the 7th. So we had a case where there was a bully in the school, and he'd come in the middle of the year and he was picking on a number of students. And when it was brought to my attention, I had him and his mother come together into my office, and I spoke to them about no bullying is allowed here. And I thought we had an understanding until the next day at recess. His teacher brought him in and she said he just punched so-and-so in the mouth. And I called his mother and said, come get him. So the next time I had a student leadership council meeting, one of the students said, what happened to X? And I said, I expelled him. And I told them that I'd had this meeting with his mother and him, and then he punched somebody in the mouth the next day. And I said, I will not tolerate any form of bullying here. And one of the 8th graders, bless his soul, he said, Dwight, only we can stop bullying. He was in the 8th grade. It's like, wow. And there wasn't anything I could say about it because he was right. If the class is with somebody all the time, the adults are not. If the class will allow disrespect among each other, it can grow. We have to teach all of the students, not just the adults who are in power, but all of the students, what it means to be a friend, what it means to be supportive. And if we don't widen the culture, all we're going to be doing is reacting. We can be proactive. And I would just like to encourage us to do that.
Yeah.
Yeah, can I follow up? On that?
Yeah.
So when my daughter was first diagnosed, and we were at a Christian school, an elementary school, and I thought in my mind that was one of the safest places for her to be. We'd been there since she was in kindergarten. And we were very proactive. Like I mentioned, we worked at the school, we talked to all the parents, and then we followed up with the students with the parents' permission and let them know when we were going to do that, etc. One of the students went home, and the parent, because of her own fear, and this was a child that my daughter thought was one of her best friends, told her daughter, you can no longer play with her. She's not welcome here. And you can't go to her house. And she came back to school and told that to my daughter in front of the entire class.
Oh my gosh.
And that set the stage, right? And it's all fear-based. So that's why I'm so big on this awareness, like the seizure safety, the awareness in general, the communication, the parent advocacy, talking about it, having our children talk about it. Like when I went this year to talk, remember when I went this year to talk at the stroll, right, here in Lansing, and my daughter wasn't going to come because she didn't want to stand in and own that. And then she put on her profile that she has epilepsy. She stepped into it, right? She's getting her own voice, helping them with that safe space to have their voice, but then also having that voice and trying to do it in a respectful way. There's times definitely to be that advocate and to push and be that mama bear, and I can be that mama bear all day long, but you're going to move people, you know, like they say, you attract more bees with honey than you do with whatever the saying goes. So, you know, but we have to, the awareness and the knowledge and the fear is what I think prevents people. It's that fear of the unknown. That's why society, people go to what they know. They're afraid of feeling silly or being uncomfortable. We need to get comfortable with being uncomfortable. We need to step into that space, and we need to model that as parents, and we need to help model that with other parents and our children. And just, we have a lot of work to do, but I believe we can get there.
We do, and we can, and we are, and we will. You know, I just want to thank you both so much for sharing perspectives, practical, you know, advice, but also this deeper wisdom of how to create something different, how to be proactive. I want to encourage everyone right now to put your questions in the Q&A. We've got 10 minutes for that. And as we do it, I think something that I have felt really moved by today is about building that culture. And so when we talk about the Epilepsy Foundation of Michigan, yes, we are talking about programs. We're talking about conferences. We're talking about support groups. We're talking about strolls. We're talking about seizure first aid training. But I think, you know, an invitation to all of us is come let this be a place where you can belong. You know, be in community, don't be alone, and know that we're going to keep practicing. We'll make mistakes as human beings, but we're going to keep practicing being there for each other, because that is how we build something different. And so, you know, if you want to get involved in one of those support groups, please show up. We have them. If you need to call someone, we've got that Here For You helpline. We've got people who have been on this journey for a long time, and people who have seen it turn corners and move in different directions. So you are never alone, and that is what we are here for. So please do put your questions in the chat. I would actually love to ask you all, just as you've been here today, what is something that encouraged you to hear, either from each other or just in the conference, something that you've noticed that you're taking with you? Yeah.
Are you asking us, or are you asking?
Yeah, I'm asking you.
Sorry. Sorry. I thought you were asking the group as a large to put into the chat.
Oh, no. That's also a good point, though. I'm just asking you that while people put in their questions.
Okay, very good. Very good. Yeah, I think the whole, you know, the transition conversation today was obviously very, very relevant. I think also, Dwight, what you mentioned about, you know, go meet with when you're at the college, go meet with the RA, go meet with that student services leader or director, I think you said. Those are so important. And I also want to encourage people. I was talking to a parent recently, and they had talked to the school about what happens if my child has a seizure. And this is relevant to school or college, right? What happens if my child has a seizure? If you have to call for help, or if you can follow my action plan, and if you call for help, or what if rescue meds are needed? This was what it was. If rescue meds are needed, can you administer them? And the school said, no, we cannot, but the fire department can. And the parent reached out to the fire department, and the fire department said, no, we don't have that, and we couldn't do that. So it was taking it a step further and just reaching out and making sure. So that's part of that whole transition planning. And then just doing the research and not just trusting that people are going to know what to do, but then asking the question and follow up, like follow that chain. If they say it's going to go here, well, then talk to that and make sure. And those are things then when you go into college that you need to do as well.
Yeah.
Let me piggyback on what Nicole just said. When you have this conversation, say point blank, I need you to be my advocate or our advocate, because I can't be here all the time. Can you do it? Now you got them on record there. And nobody in his right mind is going to say to you, no, I can't be an advocate for your child. They're not going to be able to do that. You put them on record. We need you to be what we're paying you to be.
Yeah, that's really good. That's good advice. Yeah. get them to say that, you know, and that, or that opens up a larger conversation. Then also like, well, what do you need for that? You know, how can I be that? It moves to the how level. Someone has asked if about suggestions for elementary school students being able to be connected to the foundation, and I'm actually going to answer that one. One of the things I want everyone here to know about, whether you've been here more times than you can count or whether this is the first time you've been at this conference, we have a summer camp for students with epilepsy called Camp Discovery that takes place every year in July, and it is connected to North Star Reach, which is a wonderful camp center in Pinckney, Michigan, and it is for children and teens with a variety of chronic health conditions and disabilities. That is what they do, and they know how to have great medical staff on hand. And these kids get to do things that kids want to do and get to have the camp experience they've been longing for. And I can tell you that in addition to just really having fun and building peer relationships, it is transformative for them to know other students their age with epilepsy, or perhaps if it's another condition. And also to leave just feeling empowered in that part of themselves and in their full selves. And so we've seen that happen again and again. And so I want everyone here to know about that. That is how your elementary school age children can get involved with the foundation. Wonderful. Any other questions from folks? I'm going to ask one, and then we'll give just another moment or two for some questions to be put in the Q&A feature. I guess I want to ask a question about self-advocacy with students. You know, Dwight, how would you encourage a student with a disability to be a good self-advocate?
I think that what the student should do is go, now remember, I spent 10 years as the Dean of Students. I think the student should go to the Dean of Students because that's what it means. I am your spokesperson. And tell her or him, this is my situation and I need support sometimes, not all the time. I don't need you holding my hands every second, but you need to know that this is something that I am personally dealing with. Just being frank about it. Now, if you ask me, when I was in spaces where I was among the, what shall I say, minority, did I always do that? No. I was the first African American ever accepted in my theology school. I should have told somebody what kind of support I needed, but I didn't. And it was hard because I'm in Maine and there are less than 1,000 Black people in the whole state of Maine when I'm there. And I'm the first one in the school, but I did not advocate for myself. I was fortunate because there were a couple of people, adults in that space who advocated for me. I teach my children that you need to be your own spokesperson and that you can do it because I have faith in you doing it. And if it's necessary, I will practice with you before you do it. And if you find that being your own advocate does not get you as far as it should, I have your back. You can believe that your daddy has your back. And so with them knowing that and also not wanting me to come in, that also empowers them. But they know if it has to happen, it's going to happen.
You're there, which is huge. Someone has asked a question about rescue medications, and this is really good. And I also wanted to mention when Nicole said, you know, the school said no. I mean, the school does need to do that. And we also provide rescue medication training because that's so important, you know, to be able to do that in a timely way. And it's actually, you know, anybody can administer rescue medication. They just need some training on it. But one of the things this person mentioned also is that her daughter's under 5. And so, and Dwight, I know this will be new information to you, but So for younger children, under 5, like the rescue medication to stop a seizure, like that might become prolonged, is diazepam, which is administered rectally. And was just saying, like, her daughter has this big fear of like, what happens if I have a seizure and other kids are around. And so I think, really talking with the teacher to make sure that, if they need to move the kids out of the room first, if they the other students, and provide that dignity and provide that privacy, that is really, really important. But of course, as children get older, 6 and up, they can use the nasal spray rescue medications, and we can provide training on those. And then one final question here. What about siblings? What is their role as an advocate, or, just their fears that they may have about their sibling with epilepsy? So this person said, I'm realizing they might feel overlooked, and, they can both be empowered to advocate and also, also given their own care. So I'm just wondering if the two of you might want to speak to that.
Yeah, so the North Star Reach does do a program for siblings as well. They have information out there. There's also, I don't think there's currently any other training on siblings, but there's training to do training for siblings. It's such an important factor. I have 5 children, like I mentioned, so 4 older children, and yes, they did feel impacted by that. And on the bright side, my oldest said, I didn't do some things that maybe some of my peers did because I knew life was hard enough and I didn't want to risk making it harder for you, Mom. So that was on the good side, because that kept him more on the straight and narrow. Not everybody does that, right? But they can't be overlooked. I think it's so important as a parent. I mean, there's so many demands put on us as a parent in these situations, or a caregiver, but it's so important to acknowledge their role, and then to also help give them a role, right? Empower them to have a role in that, gives them something to do in that moment. And I think it is also helpful.
That's great.
Great.
Anything you'd like to add?
Yeah, and I'll go back to my mother. My mother had me, and then she lost a set of twins. And then 2 years later, on their birthday, she had a daughter, and I'm 4.5 years old. And I really was not into being replaced as the baby. So my mother called me to her side and she said, I need your help. Because my father was somebody who was in and out, and he might even disappear for weeks at a time. And so when she said she needed my help, she trained me in how to help. So I made formulas for my 5 younger brothers and sisters. I changed all their diapers. I babysat. She trained me how I can be of use rather than just be a spectator. See,
Yeah.
If you've got children, help them understand how they can be of use to someone who may have more needs or different needs than they do. It's a team affair. And me, I wanted to be a professional football player. Even though I never won any championship with football, I won 5 straight with basketball, but they're all team sports. Both of those are team sports. You know that sometimes you're not going to be in place, but you got to cover for somebody else. You got to think like a team if you're in a family, not as an individual as you might if you were a golfer or a swimmer, but it's a team. A family is a team where you cover for some other people. Sometimes you're in front, sometimes you're in the back, sometimes you're in a support position, but we're helping each other. Do that with your children.
That is so beautiful.
So beautiful and so true. And, I think also the child with a disability can know that they're able to help with their siblings. That sense of empowerment as well, of just sometimes I think a lot of children growing up feel this interesting, sense of guilt or fear around being burdensome in some way, because they grow into adulthood and fear that. But of course, again, we all have needs. We all can participate in caring for each other's needs, and that's what we do. That is the culture we are trying to build. So I want to thank both Dwight and Nicole for this really, really beautiful conversation. So glad we recorded it. And before we begin, an optional session for those who want to stick around, we're going to have Nicole stay with us. And that's going to be called Cultivating Self-Care as Caregivers. I want to thank every one of our speakers and panelists for guiding us into best next steps for the school year. And more than anything, I want to thank all of you for being here, who have joined us today, who have taken this time to learn together. So for this last session, we once again invite our dear friend and advocate, Nicole Fitzpatrick, to share more on the topic of cultivating self-care as caregivers. Thank you.
So yes, I am so honored to be able to talk about this topic, and thank you for those who are sticking with me through this last hour of the day. I know Zoom can be a very long and taxing time, so I do think this is a very important topic. Cultivating self-care as caregivers. Thank you for the foundation for letting me speak to this topic. My sincere hope today is that you'll learn to recognize the signs of caregiver burnout. You'll discover some new ways to care for yourself, and you'll walk away with the motivation to act on behalf of yourself. You do that so well for those that you care for. It's time to make sure we're doing that for ourselves as well. So where are we? A diagnosis of epilepsy can put additional demands on the energy, emotions, and finances of a family. Parents are often so focused on the safety and care for their children that there is little to no time or energy left for themselves. And while there's no easy answer for this dilemma, I have to acknowledge that there is no easy answer for this dilemma. With a little creativity, it is possible to find the balance that includes your own self-care. And as I go through this today and talking, I recognize that I'm going to make some statements and comments that I speak in generalities. It's not the same for every person, right? I mean, everyone experiences this differently and at their own level. We do typically have some basic human needs as individuals. Physical needs, we talk about those: food, water, warmth, safety. Movement and exercise are some basic human needs. Purpose and challenge, spiritual connection, and structure to the day, and some control over one's environment. When these needs are not met, we can become deeply stressed. And the diagnosis of epilepsy for your loved one can impact one or more of these basic human needs. So why self-care? Because I think when you say that word, most people go, self-care, I don't have time for that, but it's important. So stress and caregiving. Family caregivers are occasionally referred to as the hidden casualties of these situations and these illnesses. Our focus as caregivers is to care for our child and our loved one, but we are also experiencing significant emotional distress. In witnessing your loved one in distress and feeling helpless as a parent or a caregiver to be able to fix it and make it better. Family caregivers also have many responsibilities which can be very stressful, such as making important medical decisions on a loved one's behalf. And those can be decisions that have lifelong impacts, and that's very stressful. Dealing with the mental and physical exhaustion of taking care of a loved one, no matter where they are. Financial implications of caregiving, such as medical bills, long absences from work, perhaps risks of employment, perhaps having to leave your employment, all from the caregiving demands. Another aspect of family caregiving is the unsupported grief that many family caregivers experience. You've got grief associated with the vision you held as a parent for the child you gave birth to or that you're caring for. And there's a grieving process as you transition from what you envisioned to where you are today. There's also beauty in there, but there is grieving and there's a process to transition into that. Broadly, caregiving, particularly those in a family caregiver role, can create prolonged stress, and without the necessary coping skills, can really impact your health. Give me a moment while my computer catches up. Impacts of extended periods of stress. When stressors are always present and you constantly feel under attack, that fight or flight reaction stays turned on. The long-term activation of the body's natural stress response causes overexposure to cortisol and other stress hormones. This can create a physical impact, which can then disrupt almost all your body's processes. So there really is a physical component to that stress that you're experiencing. Extended durations of stress can have physical impacts on your body and create health problems, things such as anxiety, depression, digestive problems, headaches, muscle tension and pain, heart disease, heart attack, high blood pressure, stroke, sleep problems, weight gain, memory and concentration impairment. Common caregiver emotions. Identifying and acknowledging your emotions is the first step to dealing with them. You have guilt. A lot of times, I'm not doing enough. I should be doing a better job. I shouldn't feel angry or resentful. Sadness, depression, just can't cope. I can't stand for things to be this way. It's hopeless. There's nothing I can change. Loneliness, feeling abandoned. Friends and family have dropped away. I have nobody to talk to anymore. My social life is non-existent. When would I have time for outside relationships? These are things that common caregiver emotions. Back in 2020, I participated in a caregiver conference actually put on by North Star Reach, and I heard this term associated to caregiver stress, and it validated for me what I was experiencing and witnessing in others, caregiver PTSD. I mention it here because it's important to understand the significance and potential magnitude of what caregivers feel and experience when you're caring for your loved one. I think this emphasizes why building a strong self-care plan is very important. So PTSD, just by its definition, is a mental health condition that's triggered by a terrifying event that can be either experiencing it yourself personally or witnessing it. And then symptoms may include flashbacks, nightmares, severe anxiety, and as well as uncontrollable thoughts about the event. And again, when I heard that term associated for what I was feeling and had been feeling for so many years, it really did validate those feelings for me. It's important to recognize the signs of caregiver burnout. They can look similar to signs of depression, but they are slightly different because they have somewhat of an external factor, right? We're in a situation, we're caring for a loved one, and so we have that additional, I'm not going to say burden, but that additional responsibility that's causing it. So the signs of the caregiver burnout can be things like withdrawal from friends and family and other loved ones, loss of interest in activities previously enjoyed, feeling blue, irritable, hopeless, and helpless, changes in appetite, weight, or both, changes in sleep patterns, getting sick more often, feelings of wanting to hurt yourself or the person for whom you're caring for, and emotional and physical exhaustion. And I mentioned some of these things, and again, they're very uncomfortable topics and things to talk about, but there are common feelings that people do experience, don't act on them, but they may experience and feel them. And how do we deal with those emotions and those feelings? The good news is developing new habits can help us recover more quickly from the effects of chronic stress. There is hope. By developing these new habits, self-care becomes an automatic part of every day, not something extra we do. Brushing our teeth is not an everyday, normal, common experience. A lot of times for our little ones when they're growing up, but by the time we're adults, hopefully it's transitioned into that everyday comment. We don't really need to think about it. Get up and you brush your teeth. You go to bed. Before you go to bed, you brush your teeth. So these are things that become automatic. We don't have to think about them. And that's what we want self-care to be too. It's an automatic part of your everyday. So you have your brain power to deal with the other things that need your attention. So how do we make that happen? First of all, start small. Focus on 4 key areas of your life. Be kind to yourself. And I'm going to go into depth about these, but be kind to yourself. Be quiet. Reduce the noise around you and in your mind for even just a few minutes every day. Move your body, get outside, connect socially. And luckily, virtually, we have now stepped into this a little bit more, that we can do that without having to leave our home, which is helpful when you have a child with a chronic health issue. Take care of your basic needs. Put structure in place where possible to cover those food, sleep, and shelter topics. Do you remember when you were in that class when you were in school that taught you how to effectively deal with stress? No? Well, chances are that's because there wasn't one. Some people somehow throughout their life seem to handle it better, and you can watch people who are going through these experiences and they seem to be, and I say seem because we can't always judge it, but they seem to be handling it better. Maybe they've developed different coping mechanisms. And so the good news is we can learn these skills as we go forward. It isn't something that's innate, but we can learn them as we go forward. So be kind. You may not be able to control many things related to your child's situation, but you absolutely can learn to control how you talk to yourself. So be kind to others, yes, and also be kind to yourself. That voice in your head that might not always be the most positive. The trouble is what we say to ourselves over and over, we believe. Notice what you're saying to yourself. If it's not kind, recognize that and try and replace it with kind and more supportive language. Create a list of accomplishments or praises people have given you and revisit it when you're having a tough day. You can really change how you start to talk to yourself. Replenish, breathe. What brings you joy and helps you feel refreshed? There are many right answers to this question, as there are people who answer it. So the first step is to get clear about what activities would fulfill you and fulfill this need for you. Be sure to focus on what brings you comfort, not what would be good for you or anyone else. What truly brings you comfort, not the shoulds, but what really brings you comfort. And look where and how you are spending your downtime. Maybe instead of scrolling through Facebook and looking at how great everybody else's life appears to be, which might leave you feeling bad about your life, maybe the better use of time is doing something positive and energizing for yourself that leaves you feeling positive. If you don't already know what those activities might be, your first goal is to find that answer. Journal, meditate, talk to your friends on this question until you have a list of 3 to 5 items to work with. Can be a big wish, such as a trip, or a small wish, such as a nap. Whatever it is, it has to have you feeling refreshed and energized. Quiet time. Make time for yourself where you can be still and quiet. This doesn't have to be a long time, but it just has to be the time you set aside intentionally for this purpose. Even 5 minutes to start can help. Here's a few ideas you can do. Coffee break. Coffee for yourself before everyone gets up. Wherever you are, pause. Take a deep breath for 5 seconds. Hold it for 5 seconds, and then release it for 7 seconds. Repeat this 10 times, and you have 2 minutes of relaxation. Practice meditation if that's your thing. Step outside, look at the sky, feel the wind on your skin, listen to nature. Take a deep breath and let it out. Or sit quietly in a room and listen to relaxing music. These are all things that you can do to help release and give yourself some quiet time and space. And it doesn't take a lot of time. We're not talking about a lot of time there. Movement. Movement doesn't have to mean a 5K unless that's something that you really enjoy. It simply means to move your body in a way that makes you feel good. Walk outside or even within your home. Dance to your favorite song. Stretch. Find a brief exercise video on YouTube. There's so many that are out there and they're free. Work in your yard or garden. The options are only limited by your own creativity. When my daughter was very small, still in a stroller, I figured out how many steps it took to do a mile in my house. And I did a lot of laps that winter with her in the stroller. Let go of guilt. Give yourself permission to feel upset about the situation. This is actually a form of self-care, letting go of guilt. Be realistic about what you can do. Caregiving is not a one-person endeavor. Find a community. The Epilepsy Foundation provides a great resource for that. Talk to a therapist. We talked about therapists for the individuals. Talk to a therapist for yourself. Devote time enjoying their company, the company of the person that you're caring for. Focus on the good things that are happening. And recognize you are better able to care when you are not overwhelmed. Humor. There is truth to the old saying, laughter is the best medicine. And there are psychological benefits of laughter. It reduces stress, anxiety, and tension, and counteracts symptoms of depression, improves mood, reduces the stress response. It's that flight or fight response that reduces that. Enhances memory and creative thinking, improves interpersonal interaction and reduces isolation, increases friendliness and helpfulness, and increases the ability to cope with difficult situations. There's physiological benefits of laughter. Increases endorphins that the brain releases, which can improve mood. Enhances intake of oxygen-rich air that stimulates your heart, lungs, and muscles. Improves your immune system. Positive thoughts can actually release neuropeptides that help fight stress and potentially more serious illnesses. Relaxes and exercises muscles and increases pain threshold and tolerance. So, humor can be used as self-care. For some people, humor comes naturally, and for others, we have to look for ways to introduce it into our lives. Make a practice of watching something funny when you feel down. See how it can lift your spirits. Instead of flipping to Facebook, watch a funny video. It's easy for us to become involved in the day-to-day stress. So even if you have to set a reminder to take a moment to do something fun, even if it's only for a few minutes, you'll be reaping important benefits for your body and your mind. So some things to do: watch stand-up comedies, films, short sitcoms, listen to a funny podcast. There's so many podcasts out there today. Read humor-related books, magazines, or articles. Watch your favorite cartoons that you used to watch as a child. Write a silly short story or poem. Connect with a good friend who you can be silly with. Draw or paint fun images. Now, for some people, that's fun. For me, that just stresses me out. Post funny comic strips or pictures that make you smile in your office and or home. And make someone else laugh. When you help others smile and laugh, you are also sharing in the laugh and connecting with someone else. So go ahead, watch that silly cat video and share it with your friend. You'll both get a good laugh and be taking care of each other in the process. Finding and accepting help. Get creative about the help we need. Maybe it's not childcare. I hear a lot. I felt a lot. Respite was a desperate need in those times. But maybe it wasn't just about the childcare. That's where we typically focus. And then when we get that break, just as a side note, sometimes we get that break and we step away, then you're dealing with more guilt and worry. But maybe there are other ways that people can help you. Maybe it's running errands, cooking a meal, cleaning, picking up other kids, or simply having coffee once a week at your home if you are more comfortable staying at your home. Be clear about what would be helpful, ask, and then let them do it. That's one of the hardest parts, is letting them do it. And all of this first requires the acknowledgement and to let go of the misconception that one person can do it all. And if they can't, then they are not good enough. It gets back to that negative self-talk and what we say to ourselves. It requires us to get creative about what we need. Be clear again on what would be helpful, ask, and then let people help you. Finding support. Building a community of support takes time and commitment. Accepting help is also a key component for finding support. Set up routine calls with a close friend or family member. If someone expresses interest in helping more, let them. Let them learn how to help you more. Connect to a support group. We've talked, there are various support groups, and the Epilepsy Foundation is a great resource. Don't hesitate to seek professional help for yourself. That's That's not a weakness. That actually makes you stronger. Consider making an agreement with a spouse or a partner to alternate caregiver times so you can each step away. Again, it's really limitless based on only your creativity and willingness to try something new. Make self-care a routine within an unpredictable day. We talked about those basic human needs. One of them was the predictability of your day, and we like routines. And that's one of the hardest things about epilepsy is it's not a routine. It's not a subject that we can predict when it's going to happen. It really disrupts our day and our lives. But schedule your self-care time like it's a doctor's appointment for your child, that you wouldn't miss that. Plan ahead of time for your activity. And when the time comes, you don't have to think about it, you just do it. Set an alarm on your phone or radio, and when the alarm goes off, just get up and do whatever you had planned. So I think these are some of the key things that I would say are very important for managing through self-care. I know I left us a lot of time for Q&A, but I know it's also been a long day. So that is the end of my presentation. I do have some resources that I've collected over the years that I have found to be very helpful, and can share these out through the foundation if people would like.
Such a great resource, Nicole. I mean, I think I want to thank you for just naming these things, honestly, both the challenges and the needs and the possibilities. And I think you're a great example, as are so many parents who are involved in our foundation, of being able to do that, naming the challenges, naming the joys, naming the possibilities, and also really getting out there and practicing it. And to anyone, if you feel like, gosh, my self-care is waning, like I have really been struggling with this, just know you can always start again. And you also don't have to do it alone. Even though we say self-care, it is care for the self, but we can surround our lives with wonderful people who encourage us and who add to us. So that is a wonderful thing. There is some time for questions. If you have some, you can put them in the chat. And, Nicole, I guess could you share with us some of your own practices, that really feed you and help you?
Yeah, I think the biggest thing has been finding that community in that space and the support groups. So I do participate with the Parent Connect group through the foundation, and it has been a lifeboat for sure. And then the caregiver conference that we did through North Star Reach, that experience for my daughter was instrumental for giving her some confidence. And like we mentioned earlier, having her come back from that and, have those quote unquote normal childhood experiences was a beautiful thing. But then they did that conference for the caregivers, and it was the first time I had struggled alone for so long at that point in time. This was 2020, and my daughter was diagnosed in 2012. So there were 8 years that I really felt like, the foundation was there and I would go to conferences, but finding those connections, they really have evolved, I think, throughout the COVID period of time. So that's been instrumental, finding those connection points, and then those relationships, they grow from there, and being willing to step into your own advocacy role.
Yeah, absolutely. Yeah. And, I'm coming back to that caregiver PTSD. I hope when, I hope if people hear that and they, something is pinging, of just like, oh, wow, like that kind of rings true, to allow yourself to have the space of realizing, we don't need to minimize challenges that any of us may be facing in caregiving. And say, well, gosh, I'm not the one dealing with epilepsy, or I'm not the one dealing with whatever it may be, but this impacts our bodies too, for anyone who is giving care and providing care. And I think also, I remember someone saying about PTSD generally, that I heard years ago, these symptoms are a normal reaction to abnormally difficult situations, which is not to say, epilepsy is abnormal, but that sense of having the unpredictability probably is not something that we've experienced before. So in that sense, I mean that, yeah, like this is a normal reaction to something that has disrupted, our lives. And of course, it doesn't have to stay in the realm of disruption, but yeah, I just wonder, Nicole, if you would speak to some of that.
Yeah, that disruption, I think that unpredictability is a big part of it. And that's why I included it in this presentation, because recognizing the fact, like, what are some of the things we put in place for our kids when they're little, is the routines and the normal, right? We try to have this normal time you get up and the normal things you do for breakfast and all those routines. And then epilepsy comes in, and for ourselves as well. And epilepsy comes in and then throws that all aside and really makes your world feel upside down, and you're thrown into all these things. So trying to create a space and a place for when you can reintroduce some of that normalcy, like recognizing that that's happening and then try to reintroduce some of that normalcy. It really is important to make those strong self-care routines that you've cared for yourself. And, like I had said, the stress response that we get associated with this long-term stress. Our bodies were not intended for long-term stress. Our bodies were intended for that fight or flight, right? That's just a natural part, what's ingrained into us. And yeah, so we have to develop some new skills and some new habits of helping to control that and keep that in check, or it does start to take an effect on us physically, and then we can't care for that person, and then we have that additional burden, and it's just this kind of like spiral into crazy town. So we really need to make sure we're stepping into that space and that place.
Yeah, and then when you add to it on top of that, just all the collective stress that a pandemic has
financial.
provided, and every level of of collective stress in our world right now, which is big. And like, we're all feeling that. And or even just like, for most of human history, you couldn't like, sign into a phone or tap into, being a news channel of things that are going on half a world away. And so you feel all the stresses that you're encountering, even if they're not something that's happening to you directly.
Yeah.
So,
And I think we get into the habit of what we know, right? So if our habit is Facebook, we flip to Facebook because that's what we know and it's easy and we look, but then we might end up feeling worse because everybody else is taking these wonderful vacations. Everybody else is doing all these amazing things. Now we know Facebook and the social media, and that's right. That's a whole nother topic. But what we see and how it leaves us feeling, as opposed to taking that quiet time and having that cup of coffee, or figuring it out what it is that makes you feel better, calling a friend, watching a funny video, reading something positive, just reading in general, taking a walk, getting outside in nature. I know you've been a big proponent of that, getting outside and exploring and just reconnecting, finding that safer space. I think that's been that's such an important thing, and to recognize that those old habits aren't really probably serving you. And so we're going to create some new ones. And then once we've created the new ones, we don't have to think about it. We just integrate them into our daily lives, like brushing our teeth.
I love that you said that, and when you mentioned the stress response, one thing that, and this is another thing folks can know, is that we have a program for people with epilepsy who are also struggling with depression and anxiety called Project Uplift. And Andrea Thomas, the therapist I work with in that program, often talks about how the stress response is automatic. We have that in our bodies. Our bodies know how to do that, but we can learn also a relaxation response, and we do have to learn it. It's not as automatic. And so these practices help us do that. Yeah, that's really great. And how might, just a question for you, Nicole, like, how we talk about sometimes about raising children, it's a village and all of this, but how can the caregiver surround themselves with their own village too, whether that's family or friends or
I think it really does require some intentional effort, right? Because I think for many reasons, when I personally started on the journey, the routine activities, have a large family, but the routine activities that they might engage with weren't something that were conducive to bringing our child along. Or if we did, was just more stress because it was trying to manage and people didn't understand. So it's finding the place in the space where people understand. And then if you do have a family member or a friend who does express interest, like I did, I had a friend who stepped up and said, hey, you know, they're not afraid, right? They were willing to step into it. Help letting them come along and then being comfortable to let them help. That was key. And then it was also, there were friends of mine who I'd had been friends with for many years who had epilepsy, but didn't talk about it. So I didn't even know. And then they came forward and said, you know, I'd be willing to step in and be a mentor for your daughter or spend time with your daughter because I can relate and I understand, and letting them do that. And sometimes letting others step into that space can be hard. So if that's not the comfort level, like I mentioned, you know, it's thinking of other creative ways that can help lighten your load. I know when I was going in the thick of things, and seizure activity was very high, my big ask was, somebody please just come to my house and like have coffee with me. Like, I just need you to come here. I can't go anywhere. Maybe it's a phone call, and Zoom has really stepped us up, right? So now I have 5 friends that were scattered across the country, and we can connect on Zoom at various hours and laugh and just it's such a release, right? You know, we can't all get together on a regular basis, but those are things that I think are so important as well. So building your community and your space, and it's intentional. It's also identifying what is going to make you happy and what helps fill your bucket or brings you comfort. Where are the gaps in your life and how can you fill them? So it takes some reflection first and then starting small. Like, I didn't try and introduce everything that I thought about at once. That would have been just overwhelming. So, you know, the first thing was finding support and community. And then it was building more personal relationships. And then it was maybe stepping more into my advocacy role, because helping others, like along with the humor of making someone else laugh, helping others helps to reduce my stress, because I feel like I'm helping and regaining some of the control that I feel like I've lost in the situation, right? So
beautiful. Yeah, you know, and I find myself thinking about how do we learn, this is just a human question because I think it's a struggle, you know, for lots of people, but how do we learn how to receive help without feeling a strange sense of guilt? You know, it's really strange. I mean, like, we all need help, you know?
yeah, right.
And like, you think about like that moment of like asking, for a lot of people I know is really, really, really scary. But we also know that when someone asks us, we don't have the same fears
Judgment.
or feelings about it.
Yeah, we have the judgment about it, right? Yeah.
So what is,
Yeah.
you know, how do we learn how to ask and also to receive?
Yeah, I think that's probably true in so many areas of our life anyway, right? Whether it be, you know, it's amplified obviously when we're in this situation dealing with the chronic health circumstance, but just in general, I think it goes back to the whole how we're raised in that advertising campaign. I can bring home the bacon, right? I can do it all. I'm Wonder Woman. I can make it all happen. Well, nobody is. So it's coming back to the reality of who we are, understanding our limitations and accepting those. And that's not a weakness, that actually stepping into that is okay. I think our society, I do see a shift. I think we're stepping more into that space, which is a really good thing. I read a book by Shauna Nyquist a few years ago. It's called Present Over Perfect. And it was really moving for me because it was about gathering and bringing people to you and not expecting that my house was completely clean, and it didn't require me to fix the 7-course meal. Maybe it was ordering a pizza and just having some pop and sitting around the kitchen table and just connecting with people. So it's being very intentional about those types of things and letting go of some of those old school myths of what we should be able to do, and knowing that that's okay, and being okay with that helps also model for our children. They don't need to be perfect. We don't hold that ourselves to that
Yeah, we
expectation.
do have to model that. I love that. And it's a challenge, but I think that's part of the culture change too. And you use the word myth. Mia Mingus, who is a disability justice advocate and writer I admire a lot, and she says, independence is a myth. You know, like she encourages us to strive for interdependence and would say that is a mark of disability culture, because we all, again, like we all have something to provide. We all have things that we need. And living that way can be liberating, because there are so many, as you said, Nicole, so many cultural messages to just that speak to something different than that. Yeah.
Yeah, and we crave connection. As humans, we crave connection, but then we withhold it sometimes, I think, because we have this perception or want to give off this persona about the perfection of it, that we're perfect and we don't. We just let that go. Like, we're just people. You know, I have my strengths, I have my weaknesses. You know, we just allowing people to have that space. We're much more gracious to allow others without judgment to have that. We need to be nicer to ourselves. That's like that's why I said one of the first things is about being clear what brings you joy, and then stopping that negative self-talk and letting go of some of that.
Be kind to yourself. I also thought of Mia Mingus when you said that, because she said most of us are in a bullying relationship with ourselves.
Absolutely.
You know?
Absolutely.
Yeah.
Yeah. Like quiet that voice.
Try to quiet that. Yeah, exactly. Because we wouldn't say that to anyone else, you know, what it is that we're saying to ourselves.
And we wouldn't tolerate anyone else saying that to themselves.
No. Right. So like let's yeah, that's really, really, there's some great wisdom there too. You mentioned that being an advocate really has helped. It is a part of your self-care, actually, because it's really feeding something meaningful for you. And this year, our challenge of the year at the Epilepsy Foundation of Michigan is building advocates being heard. So, you know, how would you encourage someone when they feel like they're ready, they've got energy for it, to step out in advocacy?
Yeah, I think it's when you see that need and you see that gap. Like, if there's a gap in your school, it doesn't have to be this big momentum. It's stepping into that and asking questions. It's then realizing that it could benefit others, and it can start small. And like I mentioned, through my work as a parent coordinator with Michigan Public Health Institute, that parent leadership in state government, parents partnering for change, looking for ways to get training and educated and feel more confident to step into that space. Because I think it's also, here's a big one, knowing that your experience, that lived with experience, has just as much value at the table as the person who has the degree.
Yes, I love that.
Programs and policies are being established. Your lived with experience is needed to help guide those programs and policies. And when somebody said that to me for the first time, and I didn't hear it, quite honestly, really phrased in that way until I started with this job in February. Now, I've encountered people that have made me feel that in the last few years, but to frame it in that way, that told you that you have value, right? That you have value in this space and that you have something to contribute. That's
value and expertise. You have expertise. Like,
yeah, you're an expert in your child.
Exactly.
You're an expert in this experience that you've had. So I think that's important. But stepping into that, I think, is really important. And you can do it in small steps.
Yeah.
If there's other people, if you see a gap, like I said, in the school, in your community, in your family, I mean, you just step in and start small.
Yeah, it makes you feel empowered, and that's part of caring for ourselves too. So I just absolutely love this. This conversation has been tremendous today. Thank you, Nicole, for opening this up and being someone who's present to us so often at the foundation as well. And so I would encourage any of you, come to that parents group, or come reach out. We can get you in touch with others. We don't want anyone to feel like they're on this journey alone, ever, you know. And if you have felt that in the past, it's not true anymore. We are here with you, and we want that for you. So, friends, this conference has been great. Every single session has added so much. I'm so grateful, and thank you all for being here today. So